Everybody, and welcome to the continuing saga of the Budget Subcommittee 3, Health and Human Services. And I'm pleased to be joined by my colleagues, Senator Elaine Alquist, and we're so pleased to have Senator Dave Cox sitting in for us today as well. I just wanted to say we've got a lot of work on our agenda today, and we'll have some new information presented to us as a result of the passage of the historic federal health care reform bill this past week, and how it will hold your applause, and how it will impact the work of this committee and our approach to the details of our budget come the spring, and some of it I think we'll recognize as very good news. Independent of the passage of the federal health care reform, we also are very fortunate that through the good works of our leadership team here in Sacramento, our Profiles in Courage, along with our congressional delegation and the White House and advocacy groups as well, we've gotten much support from the federal government in helping us sustain our social safety net, and as troubled as it is as we make our way through these difficult times. And again, due to the length of the agenda, I'm going to ask that folks keep their comments as succinct as possible, also recognizing that some of the issues before us, as you'll see, have become moot as a result of the passage of the federal bill. So we will begin first with the vote-only issues on pages 4 and 5, and the motion is to approve both of these two items. And without objection from the committee, that will be our action. So then moving on to page 6, we want to welcome the Department of Health Care Services as we dig into Medi-Cal, the first issue being the governor's federal fund assumptions for Medi-Cal. And we also want to thank our Department of Health Care Services for your assistance as well with getting us the additional federal support, which is so critically important right now.
Great. Thank you, Mr. Chair. Members of the committee, Toby Douglas, Department of Health Care Services. First item, I was going to briefly go over the various areas where we have been able to receive additional federal funding. It's a key component, as the Chair noted, of being able to ensure our budget is balanced, and we've been working very hard and working very closely with the legislature on ways to secure additional federal funds. So quickly, the chart that's been put together is very helpful, laying out the different pieces. The first piece is the ARA enhanced staff map that was part of the ARA bill over a year ago, which provides 11.59% increase to our federal Medicaid matching rate. We usually receive 50 cents on the dollar, but because of ARA, we receive 61.59 cents, and that has secured a significant increase in federal funds. In addition, the budget assumes an extension of the ARA for an additional 6 months. That's continuing to move through. Right now it's in one of the jobs bills that the President is pushing, and we hope that that will be approved very soon, and that will lead to an additional $1.5 billion with the extension. The other pieces relate to work that we've been doing with the administration, the Obama administration, on securing additional federal funds through our waiver. Last year, as part of the enacted budget, there was a $1 billion federal flexibilities amount that was included in the budget. Of that, we worked through our 1115 hospital waiver to secure $360 million in additional funding in the safety net care pool. We have $766 million that we receive annually in that pool, and we received an additional $360 million that had been set aside for managed care expansion back in 2005. We didn't move forward with that. The Obama administration was willing to put it forward for new milestones related to some existing work we're doing on persons with disabilities related to care management. In addition, originally the Obama administration didn't allow for the enhanced FMAP, the ARA FMAP on the safety net care pool funding. They allowed that as well. So now we're receiving both the enhanced FMAP on the 766 plus the 360 and an enhanced FMAP on the 360. So that shows here in the chart the additional federal funds that we receive. We also, over the years, there's been continual concern that California has been disadvantaged by the federal Medicaid assistant rate. That, as I said, is 50 cents on the dollar, which is far lower than most other populous states and states with similar financial and demographic makeups. We have a very high poverty rate, and the FMAP doesn't take that into consideration. We are appealing to Congress to change the Medicaid FMAP rate to 57%, which is in line with other large states and their FMAP rate. The other pieces relate to our clawback payment that went into effect when the Part D program for Medicare was implemented, where we have to pay for those dual eligibles that were receiving their pharmacy coverage under Medi-Cal that switched over to Medicare. We now pay a payment back to the federal government called a clawback for the cost of the coverage that would have been covered under Medi-Cal but is now covered under Medicare. When the clawback was calculated originally, it did not take into account our aggressive rebates that we were collecting. It was done on a cash basis, meaning in 2003 we implemented some new rebate provisions that didn't actually get captured in our spending until 2004, 2005, but they were related to 2003 spending. And the federal government didn't take those into account, which means that we've been penalized on a go-forward basis for a higher clawback payment to the federal government that did not take into account the aggressive cost containment activities we did during that period of time. So we're calling on the administration to change their methodology back to 2003 that will give us additional federal funding, both in the budget year as well as on a go-forward basis. In addition, as the way the ARA FMAP increase was interpreted by the federal government, they did not include the clawback payment as a piece that would be calculated for the enhanced FMAP. That meant that we were paying a higher clawback payment than we would have paid if the pharmacy had been covered under Medi-Cal. We pushed very hard with a legal argument, received a lot of help both from the legislative leadership as well, and finally, in the last month or two, the Secretary Sebelius came out with a reinterpretation that allows us now to include the enhanced FMAP on the clawback payment, and it was even better than we expected that they interpreted and rightfully interpreted that back to the beginning of the ARA that we should receive the enhanced FMAP, and so we're receiving $680 million additional funds for that, and if the ARA is extended, we'll receive another approximately $180 million or so.
So this is the 783.8 that's mentioned in our agenda?
Yes.
And I had a question with regard to that money. There are these three programs.
Oh, okay. So the 783 is related to the waiver piece. Okay. That's to the waiver. The waiver.
With regard to those three programs, is the understanding that all of that $783 million will be spent in the implementation of those three programs and none of it to be used to offset any general fund spending on any other part of Medi-Cal?
I'm sorry, Senator Leonard, which page?
So on page 7.
Okay. The way the waiver is set up is to receive the additional federal funding, the $360 million, we have to achieve certain milestones. Those milestones relate to implementing these three programs that we were already implementing.
And then on top of the 360 from the waiver, we also get this extra 423 from the ARA.
The money will just be, by achieving these milestones, we then receive the additional federal funds that just goes to offset our general fund budget.
So the 423 is for offsetting, and the 360 is to implement these three new programs?
No, not to implement, also to offset. All of it's to offset.
All of it is to offset.
These were programs that they're saying is to the extent you can do good things in your program, reduce the cost of the program through care management, we're rewarding you with this additional 360 plus the enhanced FMAP, which we then can use to offset expenditures. Now, the piece that the complicating factor is to draw down this additional federal funds, we need state programs or our county programs to draw down the federal money. That's a requirement of any Medicaid spending, is you have to spend state funds or county funds to draw it down. We added new state-only programs to be able to draw it down, including ADAP and EAPC. We also added the CMSP program. And the issue here relates to our ability to have sufficient state funds to draw down all the federal funds. So we're working on that right now.
And that's where the certified public expenditures come in?
Exactly.
So I had a question about that. First of all, with the AIDS Drug Assistance Program,
yeah,
we're certain that that program, along with these others that are listed on page 8, will not suffer as a result?
That's right. There's no changes to those programs. What we're able to do is just, in a sense, use the spending from those programs to draw down federal funds without any changes to those programs.
So how do those CPEs work?
What we do, to the extent $1 is spent, for example, in the AIDS Drug Assistance Program, that money is certified by the state and allows us then to draw down federal funding.
So again, we're just getting credit from the federal government for certified public expenditures
that are related to Medicaid spending, in this case a Medicaid waiver.
Very good.
Similar, we had already been doing this for our California Children's Services state-only program. And the same thing there. For the spending that occurred, for every $1, we were able to draw down federal funds.
And with regard to the Mental Health Services Act funds?
We're working with the County Mental Health Directors Association to determine how much funding is available, and through that process we'll then be certifying, working with them so that the counties can certify their public expenditures and allow us to draw down the federal funds.
And would you think that we'll be able to identify sufficient CPEs for the entire amount of the fund, or
that's still an open issue that we're working through right now, and it's very complicated. It has to do with one, the ability, the interaction between other, for example, our provider fee. To the extent we receive AB 1383, the hospital fee, that would reduce the amount of expenditures that are available to be certified from the public hospitals, which is another group that we're using to draw down the funds. It also relates to some work we're doing with CMS to determine the implications of the ARA maintenance of effort requirements around local share of payments under the Medicaid program. We can't change the local share, and there are some questions around whether using the public hospitals expenditures would change the local share. So we're working.
And what's the time frame in resolving all of this?
As quickly as we can. It's complicated. We're working internally to get some data to determine what the sharing ratios are, and we're working with CMS on it. And there's new changes now in healthcare reform. There were changes around the local share requirements that will change our interpretation. So we've been spending way too much time on this. It's been over a year. We want to get it done as quickly as possible, but it's very complicated.
You are right about it being complicated. And then, of course, you're also working with the county mental health plans and the Department of Mental Health.
That's right. We're working with county mental health, and we're working with the public hospitals. There's concerns. The public hospitals are concerned with what we're doing, but we're working closely with them so they understand what the process is.
Very good. So I cut you off a while back. Do you know where you were?
I think we're done with it. Thank you.
Okay. Let's see if I've got any other questions here. So with regard to the increase in the base FMAP from 50 to 57%, that actually takes an act of Congress?
That takes an act of Congress. We're still working on it. There hasn't been a lot of movement and receptivity. I would say the senators from California acknowledged, and this has been an issue that Senator Feinstein has raised before. It's just it brings different opinions from the rest of the Senate and the House. So it's something we continue to fight for, but it will be a tough battle.
Very good. Any other questions from the committee? In that case, we'll move on to public comment. And again, if you can keep your comments as succinct as possible,
Of course.
you win points with the committee.
Beth Capel on behalf of Health Access California. We're pleased to see the additional federal funds coming to California. We will also look forward to hearing at a future subcommittee hearing about the impact of the health reform measure that the Senate has just passed the final piece of reconciliation. Thank you.
Thank you, Ms. Capel.
Melissa Stafford-Jones, California Association of Public Hospitals and Health Systems. I just wanted to note that it is the case that we have been able to work with the department and the administration on this issue of using public hospital CPEs in order to draw down the additional enhanced federal funding under the waiver, and just thought I would take a brief moment to maybe make sure our concerns are clear. We appreciate the issue being raised here today. It is the case that these CPEs have the potential to draw down federal match in great part because, unfortunately, the current waiver that we have has a lot of caps and limits on it due to it being negotiated under the prior federal administration that was looking very much to limit federal Medicaid spending. And I think it is a good thing that we're in a different situation now and have the opportunity to really get enhanced federal funding. But the public hospitals, unfortunately, due to that inadequacy of the current waiver, are in a situation where, because of the care they provide to Medi-Cal beneficiaries and the uninsured, they are providing real services for which they're spending real local dollars that they're getting no federal match. Not because those things aren't eligible for federal match, but because of the caps in the waiver. So, I think it's unfortunate we're also at the county and public hospital level having to make very hard budget choices and looking at service reductions, and it's a very, very difficult time when we have more people coming to us in need, but obviously less resources. So we appreciate the state's dilemma here. But we do have a concern that sort of by nature of how the waiver works, if these caps weren't in place, this federal money would be coming to the public hospitals to a great degree. But our concern with the approach, because we do appreciate that the state is in need of these funds for the budget, is that depending on how it's done, and that is what we're in conversation with the administration and department about, because these are services where we've actually already provided the service and expended the dollar. The county's already out that money and has provided the service. Depending on how they're drawn down, it actually could result in a negative financial loss for the public hospitals, depending on the amount and how much of the CPEs are drawn down. So that's an important part of the conversation, and we certainly think that that's a place where a line should be drawn, that shouldn't be allowed to happen, that they, to the degree they're available to drawn down without hurting the public hospitals, that's the conversation we're having, and that we're willing to have that discussion. And the other thing is there are a lot of federal audit and recoupment provisions that could put the public hospitals, at least under current state law, at risk if the federal government decides that they don't approve some of the costs that we've claimed, where the public hospitals could be at risk even though the state got the federal money. So we think it's important that that issue get worked through and addressed as well, because we are prepared to have this very difficult conversation about the use of this federal money that would otherwise be coming to the public hospitals in light of, this particular year in this budget situation. But I think we're very hopeful that we will all be working in the next waiver to get a much better waiver for the state of California that actually allows the public hospitals to get the maximum amount of federal reimbursement they can for the services they actually do provide to low-income and uninsured and Medi-Cal beneficiaries. So thank you for your attention to this.
Thank you, Ms. Stafford-Jones. Your testimony is important for us today, as well as the work that the public hospitals do on a regular basis. Thank you.
Mr. Chair and members, I'm Pat Ryan, representing the California Mental Health Directors Association. We also have been in discussion with DHCS about this issue. This is a pretty new issue for us. Counties, with regard to the 1915B specialty mental health waiver, are responsible for providing and paying for the CPEs for the specialty mental health managed care plan. This, what we're talking about here, is under the coverage initiative. So what we would be asked to do is certify the public expenditures that for uninsured clients that we would not normally be able to match. So it's a kind of a new issue for us, and we are talking to DHCS about how to make this work and be mutually beneficial to county mental health or to counties and to the state. We note that on page 8 of the agenda, there's an estimate that they think that they might be able to realize $300 to $500 million of MHSA funds. To us, at least, that's a bit premature. We have not we haven't gotten to the point where we've identified how many expenditures might be there. I'm not saying that that isn't accurate, but it's so far we've sort of agreed on maybe $100 million, and there may be more there, and very likely will be more, but we don't know for sure how much that might be. And as staff points out on page 9 of the agenda, we do believe that it's reasonable to assume that public entities, in our case the county boards of supervisors, would want to ensure that counties are appropriately incentivized to participate in this program, because we would be being asked to certify public expenditures that we would not normally certify. We would at minimum want to ensure that there aren't any unreimbursed costs for us participating in this, and that the risk to counties regarding audits is protected. And that may mean that whatever agreement is reached with DHCS or between the state and the counties is clearly spelled out either in statute or in contract, so that the agreement is legally binding. We have been assured verbally by the state that they don't want to impose any federal audit risk or financial risk on counties for participating in this and trying to help the state pull down the additional federal funds. But in return, in order for us to get the counties to participate in this, we need to make sure that they're not going to be harmed in the process. So we look forward to working with the committee and with the department to try to help out here.
Thank you, Ms. Ryan.
Hi, I'm Ann Donnelly with Project Inform, and our concern is the AIDS Drug Assistance Program. And unfortunately, we haven't been able to work with the department on this, so some of these questions may have been answered. But our concern, as you know, Ryan White CARE Acts and the AIDS Drug Assistance Program also have a maintenance of effort with the federal government. And in the last year's budget cuts, our state general funding was cut dramatically to HIV and AIDS, potentially affecting our maintenance of effort. It didn't last year, but our question would be, if these obviously can only be counted one time, does this affect our maintenance of effort in our Ryan White CARE Acts, which is what we need to draw down our federal dollars? We do know that our rebate funding can be used in calculation of maintenance of effort, so it's likely that we may be okay. However, if Medi-Cal enacts other cuts in benefits cuts and cost savings, we also count Medi-Cal spending towards our maintenance of effort, and we would like to see that calculation be redone if it hasn't already been redone. And I guess the last question that we have about that is, technically, while it makes sense that our rebates would come back to us because the spending would be coming out of the AIDS Drug Assistance Program, if it's technically counted towards Medi-Cal, will there be any confusion in terms of us collecting our pharmaceutical industry rebates? That would be our final question. So thank you very much, and we look forward to working with you on this.
Thank you. Mr. Douglas, can you offer any solace or support or reassurance?
I can offer reassurance. We worked very closely with the Department of Public Health to go through their numbers to make sure that we were not impacting the maintenance of effort or any of the other Ryan CARE Act requirements. I'm not sure I completely understand the rebate issue. The way, it would be, we're certifying the expenditures, not the actual collection of the rebates, but it's that once the rebates come back in, my understanding they're then used for actual health care services. It's those expenditures that are certified, taking into account any MOE, maintenance of effort requirements, and offsetting, making sure that we, as I said earlier, do nothing to harm the program, but just do a way to claim additional federal funds.
Is it okay to ask one other quick question?
Go right ahead. This is an important issue. It's an important issue.
Yes, thank you. So if Medi-Cal does enact further cuts to benefits, which then affects again our maintenance of effort, we can assume that calculation will be done again.
Yeah, we'll need to talk with the Department of Public Health and get that done. But I would say that this is right now. This is only for this would be impacting prior to any additional cuts. It's focus on the current year claiming. So,
thank you. Thank you.
Great, thank you. And Mr. Douglas, if you could make sure you keep Project Inform and other advocacy groups in the loop with the Department of Public Health's conversations, that'd be helpful.
Okay. Yes, I will.
Judith Riggle with the County Health Executives Association, and also speaking today for the California State Association of Counties. Wanted to associate ourselves with Ms. Stafford-Jones and Ms. Ryan's comments on the CBE issues. We do want to cooperate in bringing down as many federal dollars as possible, but these are local dollars. We're also in huge financial challenges at the local level, so we want to reduce our risk and get whatever benefit we can at the local level.
Thank you, Ms. Riggle.
Julian DeVoris with the Urban Counties Caucus, also. Okay. Sorry. Juliana Vorse with the Urban Counties Caucus. I also associate my remarks with the previous county speakers. We are concerned about the CPE discussions and the coverage initiatives because there's 9 urban counties that do coverage initiatives, and the CPEs are being discussed in the next waiver, and the counties put all the money for the coverage initiatives. There is no state general fund in that. So we are concerned about any the money coming back to the counties. Also, to date, from the previous waiver, counties still haven't been paid back for the administration costs and the coverage initiative. So we continue to have concerns with the reimbursement under the waiver. Thank you.
Thank you, Ms. Navarez.
Good morning. Allison Ramey with the California Primary Care Association. First of all, we want to acknowledge and thank the department for finding this needed and necessary way to bring down the additional funding. However, we do want to work closely and be in touch to the best of our ability, ensure that as much of the expanded access to primary care program is left intact and preserved, as a significant portion of that was cut in last year's budget.
Seeing no other public comment, we're going to move on. Just to encourage you, Mr. Douglas, to continue to work with the public hospitals on their issues. Do you have any further information you can share with us with regard to our extension and also conversations with CMS regarding the CPEs?
Related to the 360, is this the question? No more than what I said in terms of right now it's an open issue around the question around the ARA maintenance of effort as it relates to public share, the local share, and we're working that through CMS. And then the other issue, which is an open one, relates to the hospital fee, and we'll talk more about that. And a component of the hospital fee would go back to the public hospitals, which would offset some of their certified public expenditures, which impacts the modeling. So I will make sure that we stay in touch with you with Ms. Van Maren, but right now it's open issues that we're trying to work through.
Good. I just want to underscore the importance, given all of the myriad of moving parts and one act having unintended consequences on another, both at the federal, the state, the local level, that to the degree that we can keep our communication really clear and consistent, I think that'll go a long way in reassuring folks.
Great.
So the second item is the governor's proposed trigger mechanism. That's on page 12.
Good morning, Mr. Chair and committee members. Vanessa Baird with the Department of Health Care Services. As described on Table 2 of page 14, the governor's budget set a target for receipt of $6.9 billion in federal funds, which are critical to closing the state's budget gap. In the event that California is unable to secure these funds, the administration has prepared proposed reductions to compensate. These are difficult reductions to both eligibility and benefits. I will touch first on the eligibility as requested on the agenda. There are many ways to qualify for Medi-Cal. There are ways that take you on a mandatory path, and there are pathways that get you into optional categories of eligibility. Our proposal ranges across scaling back some of the income levels for some of our eligibility programs, such as the 1931B and the aged and disabled federal poverty level and federal poverty level for the blind. So that will reduce income levels and therefore reduce eligibility for those programs, with some children primarily being able to then go into the percent of poverty programs. We also are eliminating some categories of eligibility, such as the medically needy program and some state-only programs, such as CHDP and the state-only breast and cervical cancer treatment program. We also are proposing to eliminate categories of eligibility that accelerate or ease enrollment into Medi-Cal, such as what is done for the continuation of Medi-Cal services for foster care children, also through CHDP, and also accelerated enrollment for families that are applying through the single point of entry when they are applying for healthy families. They can also be screened into no-cost Medi-Cal. So we're proposing to eliminate those as well. I want to point out that with regards to maintenance of effort, we do have maintenance of effort requirements under ARA, and we had, under our list of federal flexibilities, requested the federal government to give us some flexibility so we could be exempt from the MOE provisions under ARA but continue to receive enhanced ARA funds. The world as we know it has changed with the passage of the health care reform legislation. There are new maintenance of effort requirements, and as of the date that the bill was signed, we are required to continue the current eligibility requirements, procedures, methodologies for determining eligibility until January of 2014 for adults and until 2019 for children. Because of these new provisions, we will be looking at this between now and the May revision.
Okay, I just want to make a couple comments with regard to the maintenance of effort. The whole construct of the ARA funds was to enhance the delivery of service to those most in need. So the whole idea that the administration would waste one moment on going back to the federal government to say, can you relieve us of our maintenance of effort and continue to give us the money, is completely nonsensical. Because the whole concept was to improve our health care services for those most in need. So I would just suggest to the administration that we've got limited resources, we've got limited time, we've got a lot of things on our plate. To try to dismantle what the federal government has conceived in enhancing health care for the country is just a waste of time. And the good news is that the recently passed health care reform now only enhances the level of maintenance of effort. So from my perspective, I think that's a good thing, and I hope it underscores the point I just made, that that's just a waste of time for the administration to even consider it. And the other thing that you haven't talked about, and which is a recurring theme in all of our conversations here, but I have to keep coming back to them, is the cost shifts. That by eliminating health care to any of the populations we're talking about here, whether it's indigent or children or families, their health care needs don't go away. In fact, they only get exacerbated by denying them care, which means it only gets more expensive to deal with the health issues as they become worse, and oftentimes shifted to the county, because that's where indigents are going to finally get served if we kick them off our programs. So I really would like, in further presentations to the committee, that you be forthright with us and at least acknowledge and give us some sense that you've thought about the unintended consequences, the ramifications, and the cost shifts. Because just because we won't pay for it doesn't mean it's not going to get paid for somewhere. And the cost continues to go up every day that we ignore a health concern. In fact, of course, if we only were investing a little more in preventive care and primary care and made sure that indigent people had primary care provision, we could keep people healthier longer and keep them less in need of medical care services, health care services, and certainly keep them out of the emergency room, which is only driving up the cost of health care for all of us because we're all paying for it. Senator Alquist.
Thank you. I'm glad you mentioned Tuesday's federal action regarding the Patient Protection and Affordable Care Act, because it does make some of the governor's proposals moot. And I'm talking specifically about Medi-Cal eligibility and healthy families eligibility. We have to do those things at the level required by federal law. And so you mentioned that you will have to be thinking about this, and that's a good place to start, to think about it. I think we also need to understand what the proposals will be, since you will have to do something different. And whatever you may suggest eventually needs to have this kind of public discussion for us to discuss that. And just wanted to mention also that according to NBC that the U.S. Senate passed the reconciliation bill, 56-43. Now it goes back to the House, and they're supposed to take it up at 4 o'clock this afternoon Pacific time.
Thank you, Senator. Senator Cox.
Mr. Chairman, thank you. Let me just I think I understand this, but it seems to me that with the federal reform bill that it seems like we're now going to just be running the Fed's program. And it seems to me that in fact, we will still be paying for half of it. And if that's the case, if the Feds are going to take away our ability to manage the program, they ought to be paying the whole thing. That's just from my perspective. So I'm not sure I would agree with you that it's a waste of time to not inquire about that. But do we know at this particular point, Mr. Chairman or members of the department, what the penalty is if the state doesn't meet the MOE eligibility?
Under ARA, the penalty if we did not meet those MOE requirements was that we would not be able to claim the enhanced FMAP. Under the legislation that was passed this week, it puts the entire federal match for Medicaid at risk.
Okay, so we're really pushing all the marbles out on the table then with this particular situation. And if you win, you're okay. If you lose, you're in serious trouble. All right. Thank you, Mr. Chairman.
Thank you, Senator Cox. Any more you would like to add?
Nope. I can go on to optional benefits. So the Medi-Cal program, we have two categories of benefits, mandatory and optional. I realize optional is not a popular word, and it doesn't mean that take it or leave it, and that it represents some very important services to individuals, but they are services that the state can elect to not cover.
So the federal government hasn't completely dictated to us?
Correct.
All right.
Correct. We implemented optional benefit reductions in several categories this year in July of 2009. This proposal will cut further into the optional benefit package and eliminate 9 additional benefits, which are on the list in the agenda: hearing aids, physical therapy, occupational therapy, orthotics, independent rehab, outpatient heroin detox, medical supplies, prosthetics, and durable medical equipment. Similar to the July 2009 reductions, our proposal will exempt children, pregnant women, and persons residing in certain nursing facilities. Be happy to take any questions.
Very good. Thank you. Again, much of this, in my opinion, to be penny wise and pound foolish. I know we're in tough times, but I think in these tough times we, beyond this room, need to be much more inclusive in the consideration of what can and can't be done. And I'm talking about additional revenues so we can sustain our state as to see it slowly wind itself down into the ground. I think we'll thank you for your assistance, Ms. Baird, and we're going to move on to public comment. And again, I just want everyone to recognize we've got a sizable line there, that there are great uncertainties as we move forward, as we continue to digest what the effects of the federal reform bill will have on many of the issues before us. So we're well aware of that. And again, as succinct as possible.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, here deeply concerned about these trigger cuts. We believe that the department has very much underestimated what both the governor and the administration have repeatedly said, that their intent in the trigger cut is to cut Medi-Cal down to the federal eligibility, the minimum eligibility they can do under federal law. Our analysis, our conservative analysis, shows that 1.7 million poor Californians would lose coverage. So the department has not counted all the categories. We, of course, don't want to see Medi-Cal eligibility cut at all. We certainly hope that the MOE will prevent us from doing that, but we want to be clear with the legislature what a radical proposal this is, and would call on the governor and the administration to withdraw this proposal now that the MOE is out there. Absolutely. People are sitting home worrying about this, worrying about losing their health coverage, so we hope that that will be withdrawn from the table. As to Mr. Cox's concern, Senator Cox, I don't believe that the federal health reform will change the extent to which the state-federal partnership in running our Medi-Cal program. There's still going to be a lot of federal money and federal requirements, but state input into how we run our Medi-Cal program. As to the benefits, the optional benefits, Your analysis recognized the fact that, of course, Medi-Cal adults have lost 9 benefits last year. We have poor people who have had their teeth removed and cannot get dentures. We have poor people who are simply who are going into medical debt, going without services, suffering from abscessed teeth, not getting podiatry services. So I think it's critical to look at the additional 9 cuts with the reality that people are facing today. It's inconceivable to me that this legislature would allow us to take poor people's wheelchairs away, take away medical supplies. I don't know how we expect people to stay healthy when they don't have diabetes testing strips. We talk a lot about care management in this program. I don't know how you can manage your care when you can't even tell your blood sugar level. The notion that we would take away prostheses and others is deeply concerning to us. Thank you.
You're not alone. Thank you.
Beth Capel on behalf of Health Access California. We share the concerns of the Chair and Western Center with respect to the impacts of the cuts. We would note that we believe that the maintenance of effort requirements extend not only to eligibility but to processes and methodologies, and that we would submit should be construed broadly to include many of the proposed cuts by the administration. With respect to the optional benefits, we would encourage this committee to seek information on the damage that has already been done from the cuts in the prior years and the unintended costs that have arisen from the optionals we eliminated last year. Health Access has put out a preliminary report about the damage already done, but we need to understand what's happening in our emergency rooms and to our hospitals as a result. In addition, Health Access has today put out a report about the impact on jobs of these cuts in the cuts in eligibility. We believe that the cuts that the governor has proposed in health, and if we also add in the human services cuts, literally hundreds of thousands of jobs lost, the wrong direction in the middle of the worst recession since the Great Depression. And just a final point, as we look forward to trying to solve these problems, we would note that some of the solutions that have been contemplated in prior years did not survive litigation, and we would encourage care in constructing solutions.
Thank you, Ms. Capel. Before we go on, legislative analysts, could we ask of you to provide some of the information that Ms. Capel was pointing out, that we've got these eliminated optional benefits, the 10 already, what kind of cost shifts were resultant of it, what kind of displacements and health problems exacerbated as a result of it. It would be helpful as we consider these 9 additional proposals.
Mr. Chair, Farrah Brock with the Legislative Analyst's Office. We can certainly try and obtain some of that information. We've requested some of the information, particularly about the dental elimination, from the department. We haven't received that yet. It is my understanding that the California Healthcare Foundation is doing a study looking into the impact of the dental elimination, and we can request other information and see what they can provide. Yesterday, some of the testimony in an assembly hearing gave me the indication that they haven't collected a whole lot of data yet that would really show the cost shifts and the utilization, but we'll work with the department and see what we can get for you.
Thank you.
Certainly.
So, thank you, yes, thank you, Ms. Capel. We have nearly 30 people in line. You can do the math. If everyone was respectful enough to self-limit, so I don't have to for you, your comments to 1 minute, we'll get through public comment in a brief half hour.
Chairman Leno?
Yes, go right ahead.
Gary Passmore with the Congress of California Seniors. I'll be brief.
Thank you.
First, let me say that as I read and interpret the proposals from the Department to accommodate these trigger cuts, I think California will end up with the very worst Medicaid program in the United States. And I'm not sure that's a badge that we want to carry with pride. The other point I want to make on the optional benefits is I wish we could find a term other than optional, because I can tell you that the people I represent don't consider eating to be an optional activity, and if they don't have dental care, some can't eat. We don't consider reading or seeing, and if we don't have access to eye care, we can't do those things. And in the same vein, we have tried to honestly and forthrightly engage the Department of Healthcare Services and a discussion about the new 1115 waiver that's upcoming, and an attempt to coordinate care, as Ms. Landsberg said, and to look at options to manage care that might in the long term improve care but also bring down costs. And for the life of me, I can't imagine how we can honestly talk to people with diabetes and say, we're not going to fund your test strips and your supplies, or somebody that is not mobile. We won't give you a wheelchair, but we're going to make your life better, improve care, and lower costs. It's a non-starter for us. We think you should just flat out reject these and not waste everybody's time trying to defend something that shouldn't even be on the table. Thanks.
Thank you.
Hang on a second, Mr. Chair. I want to do a little bit of choreography here, if you don't mind. Dave Helmsen on behalf of a group of manufacturers, providers, and consumers of optional benefits. And we kind of, 40 of us got together and consolidated our comments. We're going to keep it really short, but it has kind of an order, and Dr. Prieto is going to be right behind me, if you don't mind.
Go right ahead.
And we appreciate, first of all, the committee's understanding on the issue, and we support fully the staff's recommendation on this optional issue. We all talk about cost shift. It's sometimes an overused term, but rest assured that these facilities, or excuse me, these services, if they're taken away, will in fact result in immediate budget year cost increases as people are driven from using these things in the community at a few dollars a day to going to the only place they can get some of these services in an institution at nursing homes, $190 a day, hospitals or ERs over $1,000 a day. So we've also heard a lot about preserving programs like IHSS and adult day health care and those things. Recognize that the people that are participating in those programs are only in the community because they have these services to keep them there. So any savings achieved by the state in that area is because those folks have services at home to enable them to participate. And even more tragic, of course, is the fact that the elimination of these benefits will cause deterioration, chronic illness, and even preventable death in some of these folks that will no longer be able to go to Medi-Cal for their basic care.
Thank you. Doctor.
My name is Francisco Prieto. I'm sorry. Francisco Prieto, MD. I'm a physician practicing here in the Sacramento area and a volunteer for the American Diabetes Association, and here speaking in opposition to the cuts. These are some of the tools that I use every day to control diabetes. When I started my career over 25 years ago, we did not have these tools, and diabetics basically had to guess at their blood sugar. They knew that by the time they were spilling sugar in their urine, it was much too high. If they had trouble telling the difference between 14 or 18 units on a syringe because diabetes had damaged their vision, they had very few options. Almost all of them could count on the fact that they would suffer, in all likelihood, terrible complications of this disease and have their lives seriously shortened. Just in the last few months, I've had a patient who lost his job with his health insurance, could not afford his COBRA coverage, he could not afford his diabetes testing supplies or some of his medications. He developed a foot infection. By the time he realized that the situation was critical enough that he had to go to the emergency room, he required an amputation. Within 6 weeks after that, he was rehospitalized with congestive heart failure. So the lack of these tools, and this happens every day, has taken a productive working California taxpayer and made him a disabled person, and this is preventable. In the last 25 years, we've learned that good, tight control of diabetes makes a real difference, that we can prevent diabetes complications, we can extend and improve people's lives. As a physician, I'm legally held to something that is referred to as the standard of care. I think if we put these kind of cuts into place, we are going to set California's standard of care for diabetes back 25 years.
Thank you very much, Doctor.
I'm Jesse Sandoval, and I'm representing the Marin Center for Independent Living, as well as the California Foundation for Independent Living Centers today. I'm a public policy advocate, and I'm here voicing my opposition to these cuts. The elimination of what we're calling optional benefits just is unacceptable. And the elimination of services such as durable medical equipment. These are things that does the committee are you even aware of what durable medical equipment is? There's things like we think of as wheelchairs, hospital beds, positioning devices, and these are devices which are critical for facilitating individuals' independence and self-sufficiency and just functionality in society. If individuals don't have wheelchairs, they can't get to their medical appointments, they can't participate in their employment, etc. This will result in additional costs on other parts of the system. If an individual doesn't have a proper wheelchair, that results in such as skin deterioration, which results in other requirements of other medical services. So this is critical, and these individuals that require Medi-Cal, there are no other options for them. There is no other funding. This is their last resort. So, as someone said before, while we're fighting to defend things like in-home support services, if we don't also fund and support these, what we're calling optional benefits, then it's all for naught. The two go together, and this really does affect people's lives. So this is just, an unacceptable solution. I ask that the committee, seriously think about the consequences of these proposals.
Thank you, Ms. Sandoval.
Thank you.
We're going to keep going in this direction, and we'll come back here.
Mr. Chairman, Terry McHale with Aaron Reed and Associates, representing Shield Healthcare, and my thanks to you, members of the committee and the staff, for sitting through these long hearings and hearing these very difficult stories. Obviously, you get it. The staff assignment that we need to think about this with common sense in mind makes sense. I'm on the Dave Helmsen team here, and I was given the job of the ostomy bags. And to make it as simple as possible, no one's using ostomy bags because they want to game the system here. It's absolutely necessary, not only for them to live, but also for their quality of life. And I would ask that you follow the dictates that you placed in your analysis and reject. Thank you.
Thank you, Mr. McHale.
Mr. Chair and members, Bob Ackerman, representing the California Association of Medical Product Suppliers. We are the providers of DME and medical supplies to Medi-Cal patients. Just hold up for you something everybody recognizes, an oxygen mask. There's few things more essential to human life than oxygen. And if the alternative for people staying in their homes is going back to get this oxygen in a hospital nursing home, the costs are evident. And department's cost shift analysis, I think, is a bit shaky in terms of what the real impact is, not only on the quality of life, but on the quality and the cost of the services to the program. So we beseech you not to do this because the effects will be dramatic and self-evident very quickly.
Thank you, Mr. Ackerman.
Mr. Chair, members, Bryce Doherty on behalf of the California Orthotics and Prosthetic Association, the providers that fit, furnish, and fabricate the artificial limbs and devices to restore function. With me today is one prosthetic device that is provided by the Medi-Cal program. This is for what we would call a BKA, which is a below-knee amputee. This is something that obviously would restore function to make that patient individual function properly, to get them out of bed, to get them out of their wheelchair, to get them to work, and what have you. Another device that I wanted to speak to just briefly is a customized orthotic brace for an adolescent child who would have scoliosis. And as many of you are aware, scoliosis affects children primarily early on in life, particularly female children. And if captured and treated properly by use of these customized orthotic braces, will avoid neuromuscular spinal surgery to correct the deformity later in life. Scoliosis can cause diminished lung capacity and can compromise the function of the major organs, making those situations life-threatening. What happens in the Medi-Cal program, a real fiscal argument, is this device, which is custom-made, fitted, molded to the particular Medi-Cal patient, cost is reimbursed by Medi-Cal to the cost of $2,000. An adolescent child may need maybe one of these, possibly two, throughout the course of treatment before that spine reaches full maturity, at which time bracing is not an option. If the orthotic and prosthetic benefit is eliminated under the optional category, those costs would be shifted to mandatory services, which we've already talked about, which would include physician services and inpatient services. Physicians and those folks do not have the unique capacity to manufacture and fabricate these types of devices, which would leave, under certain life-threatening situations, neuromuscular spine surgery is the only option. We have stated invoices and reimbursements from Medi-Cal for a neuromuscular spinal infusion surgery to the cost of $294,000. Medi-Cal reimbursed that procedure $14,000. Bottom line, orthotics and prosthetics, even as an optional benefit, saves the state money. It will save the Medi-Cal program money. We're talking about a device that would cost $2,000 as opposed to a neuromuscular spinal infusion surgery that the state reimburses a very minor rate of $14,000. So we're talking a savings in one particular case of the neighborhood of $10,000 to possibly $12,000.
Thank you, Mr. Doherty.
Reject the cut. Thank you.
Appreciate your comments.
Good afternoon. I'm Kathy Persida with Johnson & Johnson here on behalf of our Diabetes Educational Institute as well as our diabetes company, both here in California.
As briefly as possible, please.
You got it. As you heard, the best way to manage diabetes is through most effective and cost-effective way to manage is through testing throughout the day. Patient places blood, gets the glucose reading, and then adjusts either food intake or insulin. So in addition to that, we understand that perhaps with these cuts, it would mean that insulin would be covered, but no longer would the injection device be covered to get the insulin into one's body. So we do thank you for the staff recommendation, and thank you again for your consideration.
Thank you.
Mr. Chair and members of the committee, Carolyn Jenna with the California Medical Association. Just wanted to say that California's physician community is opposed to the administration's efforts seeking flexibility under the ARA MOE requirements, but we are very thankful for the health reform that passed the other day and the MOE requirements for both Medicaid and SCHIP and healthy families there. Just to speak briefly to the optional benefits removal, we are, of course, very concerned about that. And for, just as an example, the adult dental that was removed under Medicaid last year, we do have anecdotal evidence from our members and ER physicians specifically that they are doing dental work in emergency rooms. But we're looking forward to the CHCF study on that and those impacts. Thank you.
Chris Rosa representing Bayer AdvaMed and the ALS Association. That's the patient advocacy group for those with Lou Gehrig's disease who are overwhelmingly dependent on all forms of durable medical equipment, including feeding tubes. So we thank you for your well thought out analysis and ask you to reject the trigger. Thanks.
Thank you, Ms. Rosa.
Missy Johnson with the California Retailers Association. We're also part of the Helms and Coalition. We're very much opposed, and we ask that you reject the proposal. Thank you.
Thank you, Ms. Johnson. We're going to come back over here now.
Mr. Chairman, Senators, Gerardo Pinedo on behalf of the LA County Department of Health Services. I'd like to echo some of the remarks by CAPH earlier and some of the sentiments that they've expressed on this issue and others. We are also opposed to the trigger proposals because they would have a devastating impact on the patients who we serve in LA County. For example, if medical supplies were eliminated as proposed by the administration, there is a high likelihood that patients who suffer from chronic diseases like diabetes would end up right back in our emergency departments. And this is only but one example of the many groups who would be impacted by these proposals. So we would urge your no vote on this so that we can continue to provide these services. Thank you.
Thank you, Mr. Pinedo.
Mr. Chairman and members, Tim Shannon representing Hearing Healthcare Providers of California. These are the audiologists and hearing aid dispensers that deal with the Medicaid population. As your analysis notes, there is no cost shift for the elimination of hearing aids, and we oppose that. I'm going to be very brief, but I would like to leave with you an article that was published, some actual data. It's called Quantifying the Obvious, the Impact of Hearing Instruments on Quality of Life. And the conclusion, if I may briefly state it, was a survey of 2,069 hearing-impaired individuals and 1,710 of their family members reveals that hearing instrument users are likely to report improvements in their physical, emotional, mental, and social well-being. Users of hearing instruments, on average, are more socially active and avoid extended periods of depression, worry, paranoia, and insecurity compared to non-users with hearing loss. Additionally, family members and friends are likely to notice these benefits than the actual users themselves. So we urge you strongly to reject the elimination of this benefit.
Thank you. Senator.
Good morning, Mr. Chair and members.
Welcome.
Thank you for having me and us here today. I want to let you know that today I'm representing Planned Parenthood of Marmonte. I'm a vice president with one of 9 affiliates across the state of California. I'm also representing the other 8 affiliates through and our Planned Parenthood affiliates of California PPAC Association. I'm here today to join others for requesting that, of course, you reject the governor's proposal to eliminate the Family PAC program. You've heard this, but I'll reiterate it. Family PAC saves much money for the state of California. It provides significant life-saving breast and cervical cancer screenings and prevention programs, including contraception, pregnancy testing, and STD testing and treatment. We serve across the state of California, or at least FPAC does, nearly 1.7 million Californians every year. And for every $1 that the state invests, the federal government provides $9 to match that program. Since its inception, and these numbers are from 2006 data from UCSF, but are due to be updated, but since the inception of Family PAC, the state has saved over $2 billion. What would this mean if Family PAC were eliminated? For our affiliate alone, we'd have to release or terminate 250 staff members, but more importantly, we would have to turn away about 240,000 patients annually. If accepting the governor's other Family PAC providers across the state of California collectively would turn away about 1.6 million women and men as well, and be unable to provide them reproductive health care. And we turn away, again, hundreds of millions of dollars. Let me just close with thanking the staff for a really comprehensive analysis. I think we're all looking forward to the intersection of healthcare reform, and hopefully many of these positions by the administration are outdated or no longer appropriate. But I join others in asking you to reject the governor's proposal at this time for Family PAC.
Thank you, Senator Ortiz. Good to see you.
You too, as well.
Kathy Mossberg, representing the California Family Health Council, and I want to, obviously, we want to associate ourselves with the comments made in regards to the optional benefits. We do urge the rejection of those cuts, and then want to just make a couple extra comments on top of what Senator Ortiz had made, is that, I mean, before Family PAC, what we did is the Family PAC program was created to leverage significant federal dollars, and that is what we're doing. And we're providing cost-effective services, 9-to-1 match, and they're cost-effective in their nature, as well as having the match. And so before this program, we had a program that was capped. It wasn't serving all of Californians, and you can see now we're able to serve many more Californians, closing in on 2 million, and we're able to significantly draw down some solid federal funds. So we urge you to reject that. Okay,
thank you, Ms. Mossberg. We're going to come back over here. Very good. Okay. Got our roaming mic.
It's working.
Give it a try. There you go.
Hi, Mr. Leno. I'm Carmen Rivera Hendrickson. You've seen me here quite a few times. 11 of the issues that are planning to be eliminated out of the Medi-Cal, I have to use. I have to use my diabetic. I'm a diabetic. I have a heart condition. I have an oxygen problem. I carry 6 oxygen tanks with me because one tank does not last me a whole day due to the improper medical type that they gave me. I'm on 4.5 liters of oxygen daily. And it is very hard. And as much medical equipment that I have, I still need a portable oxygen unit that's supposed to be put on this chair. And because this chair weighs 760 pounds, I cannot use a paratransit bus to get me here. I have to use other certain ways of getting here. My friend Michelle Rousey, which is also knows Mrs. Alquist, also she has a better medical insurance. She's the one that gives me the tubing that is not given to me. I use 6 of these tubes a week, and I can't afford them because they're $172 per bag for only 7 tubes in a big line that goes to my concentrator at home. I use a hospital bed. I have a Folio horse. I have a CPAP. I have a humidifier. I have several different medical equipment. If I cannot have that, I will die. I need it to be able to survive and to be somebody working in my community, because I don't like to be stuck before walls, and nobody does. Please, don't let these things go forward.
Thank you, Ms. Rivera Hendrickson, and welcome back to the Capitol.
Mr. Chair, members of the committee, I'm Sujatha Jagdish Branch with Disability Rights California. We represent Californians with disabilities, including people who get Medi-Cal services. And as you just heard from Carmen and so many other people, the cuts that are proposed would threaten our clients' independence, their health, and even their survival. Their mobility would be at risk to do really basic things like get out of bed, go to work, go to school, or even go to a doctor's appointment. And you've heard a lot of testimony also about the very serious health consequences that would result if these cuts were to take place. I'll end by saying you've also heard about the fact that the irony that the proposal is to cut the necessary services in the community, but not in hospitals, nursing facilities, or other institutional settings, and the fact that the care is much more expensive in those institutional settings. I'll just add that in addition to the expense, providing those services in institutions and not in the community violates the very principles of the U.S. Supreme Court's decision in the Olmstead case. Thank you.
Thank you. And again, if you could please keep your comments to a minute, we can get moving to our next subject. Go right ahead, sir.
I just wanted to address the fact that I am a former foster youth, and my name is Marcus. And transitioning from care to independence is really hard because at age 18, unlike other youth who have the parents to help them out, we don't have anybody. And I know it's the state's job to take care of us as far as being our assumed parent. But on Sunday, a bill was passed that stated that youth fall under their parents' insurance until the age of 26. And what about those foster youth who don't have a parent? Like, whose insurance are they supposed to fall under? No 18-year-old is ever, physically able to support themselves. Like, they don't have a job that can have medical insurance that they'll fall under. And the effects on future foster youth is also important because if you have to pay for medical expenses, you don't have, the money to pay for college and the money to pay for your living expenses, and that can lead you to early debt, which later on in life will stop you from getting loans. And seeing a regular doctor versus going to the emergency room, like if you go to emergency room, you're obviously going to need to spend more money, and if we can't afford it, then the state's going to have to pay for it, and that just costs a lot of money in the long run. And there's 70,000 current foster youth and 4,000 emancipate each year. So if Medi-Cal was cut, then that's 4,000 uninsured youth. And thank you for your time, and I urge you to not support the government's proposal.
Thank you. Thank you for your comments. They're very important to us, and no one had made them yet. Thank you.
Thank you.
Good afternoon, Chair and members. My name is Portia Williams. I'm a former foster youth as well. I'm from the California Youth Connection, LA chapter. I would like to oppose cuts of Medi-Cal. As you may or may not know, a foster youth is not self-sufficient at the age of 18. So when most youth transition, they're in dire need of medical care for mental health services as well as regular checkups. For me, it really helped me as I transitioned from the foster care system. As a mother of 2 young boys, it helped me deliver my children as well as be able to take care of them for regular checkups. If this was cut, it would affect foster youth statewide. Youth will not be able to afford medical services. So what that basically means is it will cause foster youth to go to emergency rooms, which will cost the state more money. So in conclusion, what we are asking is for your support to reject the governor's proposal to cut Medi-Cal. Thank you.
Thank you, Ms. Williams.
Thank you.
Good to see you.
My name is Gail Johnson-Vaughn. I'm the Executive Director of Mission Focused Solutions, which works to influence transformative improvements in our child welfare system. I'm here also to support the current and former foster youth, and want to speak specifically to the proposal that the ease of access to Medi-Cal be removed for these young people. We move these children from school to school, from relationship to relationship, and their ability to have the ease of access is crucial to their being able to use these services. As Marcus said, 4,000 young people each year we have failed by sending them out into the world without parents, and we have a moral and fiscal responsibility to keep that provision in our law. Thank you.
Thank you.
Judith Riegel with the County Health Executives Association and the California State Association of Counties. These trigger cuts in totality would be devastating on the health of our communities, and as you pointed out, Mr. Chair, would result in significant cost shifts to county health systems and indigent health care programs, and we are already overburdened with the demand.
Thank you, Ms. Riegel.
Thank you.
Nisette Short with the California Alliance of Child and Family Services. We're co-authors of a joint memo that was sent along with CYC and several other organizations opposing the trigger cuts, particularly for foster youth. So I'll just take the opportunity to align my comments with those of the two young advocates who are here and ask you to oppose those as well. Thank you.
Thank you, Ms. Short.
Thank you, Mr. Chair and members. Kathy Sunderling with the County Welfare Directors Association. We very much appreciate your comments and the discussion today and are supportive of the staff recommendation to reject these cuts. As you have heard, a number of short-sighted recommendations and cuts here that will just shift costs elsewhere down the line into other programs and will create unnecessary burdens to coverage for people, especially the two foster youth who were just here. We were co-signers on the letter that Ms. Short mentioned. So we really appreciate it, appreciate your support of these needy Californians. Thanks.
Thank you, Ms. Sunderland.
Allison Ramey on behalf of the California Primary Care Association. I'd like to echo much of what was said before me and also add that last year with $70 million in direct program reductions to clinics, we've now seen 6 close, and we have calculated that the trigger proposal as a whole would result in almost $500 million in direct program reductions to clinics. So we are at risk of significantly diminishing the capabilities of the safety net at a time when we should be building them up in anticipation for health care reform. So we would urge you to please reject the trigger concept. Thank you.
Good point. Thank you, Ms. Rainey.
Courtney Mulhern-Pearson here from the San Francisco AIDS Foundation. I just really want to agree with a lot of what's been said already, particularly the comments by Western Center and Health Access, and also just have to take this opportunity to highlight the impact on people living with HIV and AIDS and the cuts to their dental care. As you know, dental care for people with HIV is medical care. It has, serious implications for disease progression, and so we just, any analysis that is done that could include a particular focus on people with HIV and AIDS in that cut would be really beneficial.
Thank you.
Ann Donnelly with Project Inform. We also represent people living with HIV and AIDS, and I just want to align our comments with all of our colleagues and really thank the committee for its excellent analysis and its recommended action.
Thanks, Ann. Seeing no further, is this one last public comment? No? All right. So we have given this a good debate. Mr. Douglas, do you have any other comments?
No, other than we acknowledge these are terrible reductions that we hope would never have to be triggered. And we said we're going to be reviewing as part of the May revise. It's definitely important to put a face on to it. This is, our program. We want to be able to serve all our beneficiaries in the most cost-effective way, and really hope these impacts don't occur.
Very good. So I'm going to make the motion that we do, in fact, reject unequivocally the governor's proposed trigger. Without an objection, that is the action of the committee. And we thank everyone who took the time to share with us the face of what these cuts would look like and the lives that they would impact and the severe, I would imagine, I'd like to believe, unintended consequences, but no less the real for their unintention. So we're going to move on to page 15. The third item is the governor's proposal to establish limits on benefits, expand cost sharing, and other Medi-Cal program changes. Mr. Douglas.
As part of the proposed budget, the governor, in addition to looking at ways to draw down additional federal funds, the goal is to also look at ways to better align the Medi-Cal program with other states' Medicaid programs in the areas of cost sharing, utilization control, as well as payment methodologies. We, at this point, have proposed a broad proposal that is cost containment that looks at ways to do cost sharing that could be co-payments across the board for physician services, pharmacy services, hospital services. These could be mandatory co-payments, meaning that if a beneficiary didn't pay the co-payment, they would not be able to receive the services. There's potential that there could be utilization caps similar to what other states have done. I've noted before in testimony that Texas has utilization caps on prescription drugs, Alabama on inpatient services, as well as looking at different payment changes in our methodology. We've been having meetings with stakeholders on these proposals. We've met with an array of different stakeholders. In general, the feedback, as you would imagine, is not positive on these types of cost containment proposals. There are some, such as our managed care plans, that are also payers that are ways to drive more cost-effective care. There are ways to use cost sharing that makes care provided in the right setting, or things that certain organizations might be open to entertaining. But overall, we're taking the feedback, still considering the magnitude of the budget deficit. We believe at the end of the day there are going to need to be some types of cost containment proposals within our program, and we're still analyzing based on stakeholder feedback as well as our data what's the appropriate approach to reduce the costs in the program, but still, as I said, preserve essential benefits for our beneficiaries.
Well, I appreciate your forthrightness. This is indeed broad. Overly broad, I would suggest. Also curious that we would make reference to Texas and Alabama. That is going to be our guide in approaching the delivery of health care to our most needy. I have to say, given the cuts that we have made to these programs over recent years, that this proposal could best be defined as attempting to get blood out of a rock. There's just nothing left. And again, as with the earlier discussions that we've had, the ramifications would be severe and cruel and would only, again, increase costs for counties, increase costs to human life and suffering, and would do very little, I think, to address the problem, the situation at hand, which is sustaining the health and well-being of California citizenry. And then I have to also just point out that the proposal also, of course, would require changes approved by the federal government, and that, as suggested, the legislature would only receive the notification of these changes through the Joint Legislative Budget Committee, but with no other further opportunity for the legislature to do its job, which is to craft legislation and to craft policy. And the idea that the governor thinks that we would cut ourselves out of the process, I think, is rather surprising. So we're going to take public comment at this time.
I forgot to answer one of the questions.
Yes, go right ahead.
Premiums. One of the proposals is related to premiums, which, in light of, as Ms. Baird noted, in light of health care reform, premiums would be considered a change in methodologies or the standards. So that would be something that would most likely be not considered.
Right. Thank you. So again, if you can keep your comments brief, we'd appreciate it.
Mr. Chair. Beth Capel on behalf of Health Access. We appreciate that the department has met with us about this very broad, vague proposal. We did not obtain much greater specificity in the discussions with them. We are opposed to, in its current form, the so-called mandatory cost sharing means that a provider, a doctor or hospital could simply refuse to provide care if a poor person couldn't come up with the $1 or $2 in order to meet their copay. We are also extremely troubled by the notion of limits on hospital stays. We wonder whether this would survive legal challenge. We would point you to litigation in other areas where the Americans with Disability, in-home supportive services and the like, where limits on services have been challenged under the Americans with Disabilities Act. Finally, we would note we'd like the opportunity to work with you and your staff and Senator Alquist in building on some very good work she had done, and Senator Alquist has done in earlier years with respect to hospital-acquired infections and never events, and building on what's in federal health reform in that area. We also explored that with the department and would like to have the opportunity to explore that further as the months go on. Thank you.
Thank you, Ms. Capel.
Elizabeth Landsberg with the Western Center on Law and Poverty. We share the chair and the concerns raised in the analysis about the incredibly broad trailer bill language submitted on this, and look forward to the opportunity to actually review a concrete proposal. But we're very concerned about the ideas that have been put forward. Data clearly shows that when you impose cost sharing, people go without needed care. So the cost shifting questions that you've been asking, Mr. Chair, we would want to look at as it relates to this issue as well. Thank you.
Thank you, Ms. Lansbury. We're going to start now and get ourselves a little bit of order. Go right ahead.
Thank you, Mr. Chair, members of the committee. Carolyn Gino with the California Medical Association. Would like to thank you for your comments as far as the legislature's involvement in the future on these cuts. We would like that to stay here in this House so that we can look at the impacts that they would have. As far as the utilization efforts that the administration is looking at, we are still assessing the impacts of the health reform bill on those. But as far as some of the cost containment measures that have been put forth, like possible mandatory copays, on the ground for our membership, even if a copay is said to be mandatory, if it's $1, $2, $3, or $5 for an ER, as some of the voluntary copays are now, our members that are participating in Medi-Cal are not going to turn those patients away. So in effect, it does become a rate cut, and it's a concern for us as far as the number of providers that will continue to provide services to that population. So thank you. We urge your opposition.
Mr. Chair, members of the committee, Gary Passmore with the Congress of California Seniors. I, too, was among the stakeholders that met with the department to discuss this, and frankly, I liked it vague better than I liked the specifics of what I heard. I guess I would use the example that I shared with Mr. Douglas with the idea of going to a Texas alternative on limiting the number of prescription drugs under California's Medi-Cal program to 3, which is what Texas does. I'm not on Medi-Cal, but I'm like a lot of people that I represent, seniors. I take 9 drugs. And I guess my question is, would I be best off taking my drugs for my heart arrhythmia or my chronic heart disease or my diabetes or my blood pressure or my high cholesterol or my shingles? Because I certainly couldn't take it for all 3. I mean, for all of those, if I were on Medi-Cal. And as a piece of advice to Mr. Douglas while we're here together, I guess I would suggest that you also look at the fact that Texas has a significant oil severance tax to generate revenues. Thanks.
Thank you, Mr. Passmore.
Good afternoon. My name is Dr. Paulo Troyan. I serve as a medical director of the Sacramento Center for AIDS Research, Education, and Services. I am also an associate professor of medicine with UC Davis. My testimony today reflects my personal opinion and the views of CARES, but not the views of the University of California or of UC Davis. CARES is the largest provider of HIV services in the Sacramento region and the second largest in Northern California, and we're opposed to the administration's cost containment strategy proposals. Like many facilities similar to ours, CARES serves the medically underserved, with more than 70% of our patients below the federal poverty level. More than half of our patients have disabling AIDS complications and are therefore covered under Medi-Cal. The proposed increases in cost sharing, as stated by others, as well as the utilization control on the available services, will increase to the numbers of HIV-infected individuals that drop out of care due to their inability to meet this added financial burden. And as articulately pointed out by the chairman, without access to care, these individuals will present at a later time with life-threatening complications that will be far more costly to treat them. Furthermore, the cost of providing medical care for this complex disease already significantly exceeds the Medi-Cal reimbursement for the services. Therefore, the proposed adjustments to the provider rates will make it more difficult to remain financially viable and to be able to continue to serve Medi-Cal patients. Thank you.
Thank you, sir.
Courtney Mulhern Pearson, San Francisco AIDS Foundation. Just want to echo the statements of Dr. Troya. Again, it's very vague, but we're concerned about any proposal that would limit benefits and expand cost sharing to this population. People living with HIV in Medi-Cal are disabled. They take on average 4 to 6 medications a month. Any prescription cap for that population would be very problematic, to say the least, and also shifts costs to other state programs. So again, just bringing up that issue, this is not necessarily a cost savings in this population, but it increases burden on ADAP and acute Medi-Cal. And I think that's it.
Thank you.
Ann Donnelly with Project Inform, and I also would like to echo Dr. Troya's concern about provider rates. As you may know, we've just lost in the San Francisco Bay Area one very, very important and competent HIV specialist because he simply could not maintain his practice, and his rates are actually higher than the Medi-Cal rates are currently. So we're really concerned about HIV specialists staying actually in business at all and certainly able to serve Medi-Cal patients. That's incredibly important. As Courtney Mulhern Pearson mentioned, the other cost containment measures significantly affect folks with HIV, will lead to much worse health outcomes and are cost shifting, both to the AIDS Drug Assistance Program, also to acute care, also to hospitalization. We're extremely concerned about those, and we oppose anything that hurts individuals and that shifts costs. I would mention that we believe that while this will come far from solving the problem, that there are other places the department can look, and one of those areas from the HIV experience is collection of rebates, aggressive collection of rebates. We've found that by negotiating in a multi-state negotiation at the federal level for the AIDS Drug Assistance Program, we've been able to get significant supplemental rebates on top of the mandatory rebates. And since the inception of the ADAP crisis team at the federal level, we've averaged about 46 cents on every dollar spent on drugs in rebates. So we think that's a place that the department can look. In addition, we'd like to see the calculations about the increased mandatory rebate with the passage of health care reform and what additional revenues that will bring to the state, as well as there's something known as a consumer price index penalty. And all of the drug manufacturers took significant increases in their drugs in the advent or anticipating health care reform. They have to pay that amount back to the state by law. And since anything over the consumer price index, and since consumer price index has been actually negative in the last several quarters, this could be a significant revenue area that we'd love to see a calculation on. Thank you very much.
Thank you, Ms. Donnelly.
Allison Ramey on behalf of the California Primary Care Association. First of all, and just generally, we are opposed to any additional reductions to the Medi-Cal program. For clinics, Medi-Cal is a substantial revenue source, and our members have been very clear in saying that they just cannot take any more. Additionally, we would like to thank the department for reaching out to us as one of the stakeholders to have the conversation of how can these cost containment strategies be as least harmful as possible, but what we've heard again from our members is they are all harmful. What standed out most was part of the utilization controls related to the cap on pharmacy prescriptions. Again, clinics see a number of chronically ill and elderly patients, so for them to even think about capping the number of prescriptions they can give, not only is it unimaginable, but clinics cannot do so because they have to provide a certain quality of care to their patients. So they would simply absorb the cost of not being reimbursed for all the prescriptions that the patients need. So again, very adamantly opposed to this, but do appreciate the department taking into consideration that stakeholders should be heard.
Thank you, Ms. Rainey.
Chairman and member, Barbara Glazer with the California Hospital Association, representing California's 400 hospitals. We too are very concerned about the administration's cost containment proposal. The proposal is not detailed, and we would hope that you would not take any action on it until we do know more about it. From what we do know, though, it appears to be a way to simply shift costs onto other health facilities, and we would hope that you would reject it ultimately.
Thank you, Ms. Glazer.
Melissa Stafford-Jones, California Association of Public Hospitals and Health Systems. I'd like to echo many of the prior comments. We do believe this is too general of a proposal and would hope that specific proposals be considered individually by the legislature, that they be afforded that opportunity to look at those things because it is a very significant concern, the impact on our patients who, as the chairman said, their needs for health care don't go away just because we place these artificial limits. I also want to note something that I think is very important in the analysis, which is although this is often discussed as the $750 million cut, when you consider the federal match, it's a more than $2 billion cut to the Medi-Cal program, which is just a level of cut that I do not think the program can or should absorb at this point in time, given the increased need for it in terms of the safety net and for Californians. Thank you.
Thank you, Ms. Stafford-Jones.
Mr. Chair and members, Sharita Lane with the California Children's Hospital Association. We also, like my hospital colleagues before me, are very concerned about the cost containment proposals. Children's hospitals in aggregate treat over 50% of their patients are in the Medi-Cal program. And as Ms. Stafford-Jones mentioned, the proposal is actually quite significant, with being well over $2 billion. any change to this program to that magnitude is going to have serious consequences on the vulnerable population that we serve. And as others before me have noted, we would certainly hope that legislative and stakeholder input would be critical, and we do appreciate the stakeholder participation that has been conducted to date, but the lack of specificity is quite troubling. Thank you.
Thank you, Ms. Lane.
Yeah, Mr. Chairman and Senators, Nathan Mansky, representing the Private Essential Access Community Hospitals, or PEACH. We represent the private safety net hospitals up and down the state. Without repeating what you have heard from my colleagues, whose comments I would certainly support, I would just like to underscore one thing, and I think that's a point Ms. Stafford-Jones made about the pile-on or the substantial impact of this reduction when you take into consideration federal funds, and I think we very much appreciate that point being highlighted in your committee in the analysis. Thank you.
Thank you, Mr. Mansky.
Hi, Dr. Richard Pan, a pediatrician practicing here in Sacramento, mainly take care of Medi-Cal and healthy families.
Ubiquitous Dr. Pan.
Ubiquitous Dr. Pan. Thank you. Well, I'm going to be
pleasure to have you in our committee.
Well, thank you, Senator. Appreciate the opportunity to be here and to speak to you. I know that many people already spoke about the policy issues, but I just want to tell you a little bit about my day, actually, because I'll be in my clinic over at the Oak Park Center, Community Health Center, a place where actually we're trying to get a pediatric clinic going, where because of challenges with payment and reimbursement, we're having some trouble getting some staffing, the support staff that are necessary to really take care of a larger volume of patients. This morning I got a call from a family that they have a baby 5 weeks old who needs to be assessed this morning, and the easy thing would have been is to tell them to go to the emergency room. I'm going to add them onto my schedule today, but we're having some challenges trying to do be sure we have the supports we need for all the providers, the physicians, and nurses who are there at the clinic trying to take care of these patients. I think we really need to think about when you have things like mandatory co-pays, we're not going to turn someone away at the door because they don't have $5, but that does mean that we have less funds to provide the supports that we need to take care of the patients. And believe me, we don't have a lot of supports right now. And we're paying below market rates for our support staff and trying to recruit more, but it's a difficult time. We see more people with unemployment who basically are now coming to our clinic, but yet we have difficulty trying to expand capacity. So I think we really got to think about, certainly I'm all for cost effectiveness, but we got to think not just to shift the cost to other places, and that $2 billion for Medi-Cal and other monies, you'll be talking about healthy families later, that's money that goes into the California economy. That's for California jobs as well as taking care of Californians. So we should not be making cuts that takes things away from Californians who need service, Californians who need to provide that service. And so I urge you to really look carefully at these proposals, and if they're not going to do that, then reject them. Thank you.
Thank you, Dr. Pan. So, Mr. Douglas, you're getting an earful today.
I get an earful every day.
Yes. It would cause me no pain to suggest that we reject the proposal at this time, but given that there are still some moving pieces and such, I think it makes sense to keep this open until the May revision. So moving on to number 4, which is implementation of AB 1383, the hospital quality assurance fee. That's page 17.
Last year, the legislature adopted and the governor signed into law AB 1383, which is a hospital fee that runs for 7 quarters during the period of the enhanced FMAP under ARA. We are in the process right now of working with Center for Medicare and Medicaid Services to receive approval for this hospital fee, which will bring significant additional federal funding to the state to secure our hospital safety net system. Over the life of the 7 quarters, it will bring in about $7.6 billion to the state. That money will go both for supplemental payments to our private hospitals, our designated public hospitals, our district hospitals, as well as providing relief to the general fund. We also will be using some of that money for support staff costs to actually administer, to get approval from the federal government as well as to administer the program. It is a very complicated fee structure that has been structured with 3 different types of fees depending on the days and depending on the payer, with Medi-Cal having a different fee. We are working very closely with CMS. It's something that they've never seen before, which is why it's taking a long time for approval. We've been giving them a lot of data on why the fee model passes there's specific tests under federal law that we need to pass, and we believe we passed them. They haven't made a final ruling. They've also provided us many questions about the payment structure and how that complies with the payment rules under Medicaid law. We're working through those. We're working with the Hospital Association on the responses to questions on that front. And we're going to try to get this approved as soon as possible, as it both, as I said, it preserves our safety net system as well as shores up our budget situation.
Very good. Do you want to talk about the positions?
I can briefly. We are requesting 14 positions that will administer the program. This relates to different areas, such as collecting the fee. We will have to work similar to our existing fees for our nursing facilities. We have to work on collecting the fee. We have to set up a structure on policies and rules on collecting that fee. We need staff to be able to develop the new payment methodologies for the payments that are provided through our fee-for-service system, as well as we need staff, as well as contractual resources to determine the actual payments that will flow through our managed care plans to our hospitals. In addition, there's a lot of legal work around this, both from a perspective of working with CMS, but also as the fee is developed, we'll have issues with hospitals on paying it and structures around that. All these funds, or these positions, as I said, are funded by the fee itself, so there's no general fund impact.
Very good. Thank you for that update. And then additionally, all right, there is clearly a lot going on here. And a big success thanks to the leadership of Senator Alquist and Assemblyman Jones to get this through the legislative process, which was no small doing. But it is significant amounts of money that we'll be able to access as a result of it. So we, of course, would like to continually get updates from you so that we can follow with your progress. And then lastly, if you could talk to us just a little bit about what further CMS approval we'll need with regard to the quality assurance fee implementation.
Sure. We'll need lots of federal approvals. The way the legislation was structured to ensure the security of the structure was that the fee and the payment structure would not be put into effect until all federal approvals were received. We need federal approval from the tax, the fee structure. We need federal approval on how the payments will be done in the fee-for-service system. We will need federal approval for every contract change for the managed care plans. So all our managed care plans have to be approved for the new rates. So it's going to take a lot of work. We're pushing on this. It's going to take both work from a policy perspective, working through CMS, and then pushing them to understand the priority of our contracts and the process, knowing that they're working with 50 other states on managed care contracts at the same time, but trying to push it as quickly as possible.
It sounds like there's going to be a lot of upfront work for these new positions as we get the CMS approval. Will this present any kind of cash flow problem for the department?
Once we receive approval, one of the big cash flows is actually something we're working with the Hospital Association on. It's going to be the impact on the hospitals of paying significant fee that goes back all the way to April and maybe even earlier of 2009. So because of that, we'll have to work on how we send out the fee, so there could be multiple fee requests from the hospitals so that we don't end up adversely impacting the hospitals by trying to get a huge infusion of dollars at once.
And when, best case scenario, might the federal money start flowing?
I just don't have any idea at this point. It's just so we're very early in the process, is what I would say. I mean, but it could go quickly once we get it. Yeah.
All right. And before we move the item, is there any public comment? I don't need to encourage it. Everyone stay seated. Stay seated.
Wow.
Very good. So then the motion of the committee will be to adopt the funding for DHCS staffing, just to underscore, not general fund dollars. And without objection, that's the order of the committee. And, of course, not to overlook the thanks that we owe to our legislative leadership and also to the department in getting us to this point.
Yeah, I will testify to this since it's the one positive thing on the agenda. That is just
yes.
Very good, and we're pushing hard on it.
Great. Item number 5, proposed 10% reduction to public hospitals.
So as part of the existing hospital waiver, as I noted, we received $766 million in federal funds through the safety net care pool. The majority of that money goes to the designated public hospitals that offsets their uncompensated care costs. Another portion of the money goes to federalize some of our state-only programs that we've discussed earlier, including our CCS program and our BCCTP program. In the past budget, it was enacted to take $54 million of the dollars that had been going to the public hospitals, and instead of using it for relief to the public hospitals for uncompensated care, it would be used to further federalize these 4 state-only programs and reducing the general fund budget impact by doing so. We're proposing to continue that for another year, for assuming the waiver is approved, the new waiver. We would expect that there would at least be the same amount of federal funds of $766, but we're expecting to receive a huge increase in that amount. Of that new amount, we would be taking this additional 10%, and like we did in the past year, to offset general fund costs.
Well, I know there's a lot of work yet to be done on this, and that it will then come back to the legislative policy and fiscal committees for review. Not surprisingly, we've got some letters of concern from the California Hospital Association's Disproportionate Share Hospital Task Force, and I suspect someone may be here to comment on that. So anyone who'd like to speak publicly on this, please do join us.
Melissa Stafford Jones, California Association of Public Hospitals and Health Systems. We do oppose this cut. These are federal funds that come to the public hospitals for services they provide to uninsured patients. We're only getting half of our costs covered anyway. These services are being provided, and so it is of great concern that this is federal money being redirected away from public hospitals to the state for services they are providing. I'd also note that we don't know yet what the structure of the next waiver will be or will look like, and so to know whether a 10% cut is a workable thing or not, and what that might look like, is just something that we don't know yet, and is of concern because we all have a lot of work left to do to craft the next waiver. Thank you.
Thank you, Ms. Stafford Jones.
Barbara Glazer with the California Hospital Association. We too are opposed for the very same reasons that Ms. Stafford Jones mentioned. And this would be, of course, not the first time this was cut, but this would be the second year in a row for this cut for these hospitals.
Thank you, Ms. Glazer.
Mr. Chairman, Gerardo Pinedo on behalf of LA County Department of Health Services. I'd like to echo the comments by the 2 previous speakers, CHA and CAPH. We're also opposed to the administration's proposed reduction in the safety net care pool and the South LA Preservation Fund. If approved, these cuts would result in 60,000 outpatient visits lost in our system. Could not come at a worse time. We're seeing an average increase in our emergency departments of 16% overall in the system. We think those are largely attributed to or attributable to the downturn in the economy. So again, could not come at a worse time. We urge you to vote no on this. Thank you.
Thank you, Mr. Pinedo.
Mr. Chair, Sharita Lane with the California Children's Hospital Association, and as part of the very fragile hospital safety net, we are linked with the public hospitals by the patients that we serve, and so we also oppose the cuts to them. Thank you.
Thank you, Ms. Lane.
Mr. Chairman, Nathan Mansky representing Peach, the private Hospital Safety Net Association. We join with our colleagues for the same reason in opposing our public hospital colleagues in opposing this reduction. Thank you.
Thank you, Mr. Mansky.
Beth Capel on behalf of Health Access, also in opposition. Thank you.
Thank you, Ms. Capel. We will keep this open until our May revision. Item 6, similar proposed 10% reduction to private hospitals.
This is a similar proposal to the last item as part of the SB 1100 that was developed for the last waiver. The private hospitals now receive what's called virtual dish, which is made up of general fund and federal funds. The last year, the legislature enacted and the governor signed into law a 10% reduction to that dish payment amount, leading to general fund relief. The administration is proposing to extend that 10% reduction for another year.
Thank you, Mr. Douglas. Public comment.
Mr. Chairman, Barbara Glazer with the California Hospital Association. We would urge that you reject this 10% reduction to these hospitals. Again, this would be following a similar reduction from last year. These hospitals are all seeing more and more uninsured due to the economy, as well as more and more Medi-Cal. It's a very tough hit for these hospitals.
Thank you, Ms. Glazer.
Melissa Stafford Jones, California Association of Public Hospitals, in opposition to this cut to private safety net hospitals, which are also essential to our state's overall healthcare system.
Standing in solidarity.
Yes.
Thank you.
Mr. Chair, Sharita Lane with the California Children's Hospital Association. The state's children's hospitals on aggregate are operating in the red and are seeing more than 50% Medi-Cal. We cannot ensure the same level of access that is provided to the state's vulnerable children when we can see continued reductions in our Medi-Cal reimbursement. Thank you.
Thank you, Ms. Lane.
Mr. Chairman and Senators, Nathan Mansky, again representing the private essential access community hospitals, and certainly concur with the comments by Ms. Glazer from the California Hospital Association based upon the unfortunate results of the current downturn in the economy, which has frankly changed the payer mix in our hospitals, moving more in the direction of public pay and uninsured, which then, of course, reduces the ability of our private hospitals, their ability to cross-subsidize. And for that reason and continuing cuts from prior years, we would urge the committee not to embrace the continuation of this reduction. Thank you.
Thank you, Mr. Mansky. Ms. Capel.
Beth Capel from Health Access, also in opposition. Thank you.
Thank you. And as with the previous item, we'll keep it open until the May revision. The seventh item is the implementation of Medi-Cal managed care tax, which was AB 1422, and that's on page 25.
Another joint win last year with the legislature and the administration, and Senator Alquist was very involved in this, was our ability to draw down additional federal funds to preserve the Healthy Families Program and ensure that there was continued enrollment in the program through what was enacted was a fee through our gross premium tax on our Medi-Cal managed care plans of 2.35%, which was able to continue what had been in place before, a quality assurance fee that was allowed under Medicaid laws and had ended. We then shifted to a general purpose tax, the gross premium tax, that was then included our Medi-Cal managed care plans with other insurance entities, including life insurance and workers' comp. So this brought down new funds. It has no impact on our Medi-Cal managed care plans because we then include the costs of the fee or the tax in our capitation rates, so they are made whole through the capitation process. To date, we've drawn down over $140 million from the tax. We'll continue to receive more, but the plans are paying the tax timely based on the requirements from the Department of Insurance, and it has, as I said, been able to lead to us preserving healthy families with no impact on the plans.
And then there's trailer bill proposal to extend the sunset date.
So we are proposing to extend this program to the end of the budget year. It will either be at the amount of funding that will go to the Healthy Families depends on whether there is the extension of ARA. To the extent that there's an extension of ARA, we'll be able to direct more money back to Healthy Families because we'll get the increased FMAP to be able to pay back the plans through their capitation rates. So we have trailer bill language that gives us the flexibility depending on what the federal Medicaid matching rate will be.
Thank you, Mr. Douglas. Public comment.
Good afternoon, Senator. I'm Christy Weiss. I'm here this morning on behalf of the Local Health Plans of California, which are the Medi-Cal managed care local initiatives that provide services to a large number of Medi-Cal enrollees throughout the state. We are here to express our preliminary support for the extension of 1422, the gross premiums tax. And we worked hand in hand with the department and the legislature last year in getting that legislation through. And we're happy to support its extension, but again, I have to preface our comments and our support as being preliminary. As you know, and you've discussed, and we'll continue
on the rates.
Continue to discuss, the governor has proposed eliminating healthy families altogether, which we're obviously opposed to. Additionally, there's been discussion about reducing the eligibility in healthy families down to 200%, which would result in a large number of children being kicked out of the program. We're willing to support the extension, but we would hate to support the extension and at the same time see the program eroded. So that's why I would like to express our preliminary support.
Very good.
Additionally, I'd like to introduce one of my colleagues, Steve Schramm, who has done some work with the local initiatives and the other Medi-Cal managed care plans, who's going to make a few comments today about the issues that you raised in the agenda about the Medi-Cal rates. So, Steve.
Thank you, Ms. Weiss.
Good afternoon, Mr. Chair and committee members. My name is Stephen Schramm. I'm with Schramm Raleigh Health Strategy. We're the strategy and actuarial consulting firm that works with 8 of the public, not-for-profit Medi-Cal managed care plans. Our clients include LA Care Health Plan, Inland Empire Health Plan, Cal Optima, Santa Clara Family Health Plan, Kern Health Systems, Community Health Group, Alameda Alliance for Health, and the San Francisco Health Plan. In fact, I have next to me with me the CEO of Santa Clara Family Health Plan, Elizabeth Darrow, who is here in support of the testimony that I'm about to give. LA Care, as the nation's largest public health plan, covers almost 800,000 lives, and it is responsible for the public side of the 2-plan model in LA County known as the local initiative. Local initiatives have a very unique statutory responsibility to have a connection to and protect safety net providers. And LA Care has, as part of its mission, made it its goal not only to contract with a comprehensive network of community clinics, public and private DISH hospitals, but it also has helped them succeed in contracting with managed care entities outside of the LA Care health plan. The reason those safety net providers are so important is not just limited to California. As Mr. Douglas testified earlier, there's information included within the Health Reform Act nationally that recognizes the importance associated with safety net providers. Here in California, they provide a critical and unique set of services because of the geographic access that they bring and the type of services that they bring to the table. And those services are available for the most complex and needy of healthcare users. Not only Medi-Cal enrollees, but also all Californians. The reason I'm here today is to testify about a change in DHCS's rate-setting methodology that has an impact upon the safety net providers. What that is in the last rate-setting methodology that affected the 2009-2010 rates, DHCS introduced what's called a normalization factor. It's countywide averaging. The effect of countywide averaging was to reduce the amount of money available to LA Care Health Plan, and as a result, its safety net healthcare providers, and actually transfer that money on a dollar-for-dollar basis to its for-profit competitor. That is something that has had a significant and material impact on the financial revenue that LA Care Health Plan receives. In the first year, 2009-2010, the change represented a reduction of approximately $7 million in revenue to LA Care Health Plan and its safety net providers. Upon full implementation, in LA County alone, it's estimated this will reduce the payment to LA Care Health Plan by $36 million and transfer that money in the form of rate increases to LA Care's for-profit competitor. As we have been discussing this internally, the local health plans of California, the trade association representing the local initiatives, has met with DHCS, and DHCS instructed the local initiatives to come back with empirical data to support the local initiatives' position. We did, and we actually provided an advance copy to the committee showing the analysis that was done. And what you see in that analysis is that the local initiatives support the safety net providers to an extent much greater than the commercial for-profit plans do. The analysis showed that while the local initiatives only had approximately 2 times the enrollment of the commercial for-profit health plans, the dollars going to safety net providers was 7 times greater than that of the commercial for-profit providers. We're talking about $260 million from the local initiatives to FQHCs and county hospitals compared to approximately $35 million from the commercial for-profit providers. Let me be clear about what LA Care and the local initiatives are asking for here. They're not asking for additional general fund money. What they're asking for is for DHCS to stop the phase-in of the countywide averaging process and instead work with the local initiatives to come up with a normalization factor that does include the special position that safety net providers represent for local initiatives.
Mr. Schramm, if you can conclude.
Actually, that is my conclusion. Thank you for your time, and I'm certainly available to answer any questions.
Can I respond?
Thank you. I was going to insist upon it.
Oh, thank you. All right. First of all, I'm not an actuary, but I'm going to say that one of the most important points of our rate setting is to align the payment to the risk of the plan. And part of what we've done is not about normalization. It's about better making sure that as we've moved to our new rate methodology, that we are ensuring that we're aligning the payment that we make to a plan to the risk of the population. That means looking at a way to look at the risk scores and the profile of each of the plans based on what it costs in that county, looking at the cost of providing services in that county, and then paying for that. And that's what we've done, is we've taken the plans, the individual plans, looked at what each of the plans' costs are, come up with a weighted average for across the plans, and then take into account the risk. And depending on the risk, that's the rate they get. And we have also done a process.
On that point, and I'm not an actuary either, but from your comments, could one conclude that the department is then suggesting that the risk is greater for the for-profit than the not-for-profit?
No, because it takes into account both risk as well as cost, to the extent, if part of the reason why one of the other principles of our rates is to make sure that we're driving efficiency within the system. So to the extent that costs are higher, one of the reasons costs would be higher would be that the risk of the population is higher. As it relates to safety net providers, we definitely see that as an essential component of our whole plan structure, and we've incorporated that in both in terms of contractual requirements and the way we set up our default enrollments into managed care. There are performance goals around, to the extent that you provide more services working with a safety net, you receive more default enrollments. We've also are phasing in this process. It's only, at this point, it's 20% of the payment is aligned to the risk. The other 80% is based on plan-specific data. We are working on, I didn't realize this was going to be part of this conversation. We're working offline. We're hearing their comments. We're taking those into account. But the key here is just trying to drive a system that's aligned to the risk, that's efficient, but does recognize the safety net. It's a key part of our plans to keep part of our waiver. All those need to be components.
Had you shared any of this with us, that you were going in this direction?
Which the risk-adjusted rates? Yes, we've had discussions last year. We've had discussions when we went to the Mercer methodology. We talked about it. Yes.
And is this news to the LAO?
Thank you. Farah Brock with the Legislative Analyst's Office. Conceptually, we knew they were moving to a risk-adjusted payment system, but we certainly didn't know any of the specifics of what was going on. I think it'd be helpful for us to have an update about how this is really working, and particularly what some of the changes are that are being reflected from plan to plan. I mean, why is there such a shift? It's news to us.
All right. So how quickly could we get this? You need information before you can give us information.
Yeah, we would definitely need information first, so we'd have to have some meetings with the department and work with your staff. I don't know if I can give you a time frame right now,
Sure.
But we'd certainly start working on it.
Okay. Well, I think Mr. Schramm's comments are very compelling, so I'd like this to be addressed. Then we have another
Senator
testimony.
Leno, my name is Jeff Shelton. I represent HealthNet, the for-profit carrier that was being disparaged by the prior witness. It's helpful to understand where we are now and where we've come from. What I believe LA Care is asking for is that you pay them based on their costs, which has been the system that was initially discussed in the Mercer methodology, which Mr. Schramm, I believe, was involved in creating. So that's a cost-plus payment system. We think that's a bad idea as a matter of public policy because you are encouraging plans to be sloppy in their contracting practices. The rejoinder to that may be that the LA Care, like other local initiatives, is required to take into account the FQHCs and the other safety net providers. And we don't deny that they have that responsibility, and we don't deny that their payments should reflect some of those costs. But LA Care, as far as we can tell, is paid 12% more than we are. Do they spend 12% more to ensure that the safety net is protected in Los Angeles? We question that. And we also question the commitment on the safety net to the extent that it's supposedly so much greater than ours. For example, when the Department of Healthcare Services looks at doing plan rates, one of the things they consider is, in fact, contracting with safety net providers. We will admit that LA Care contracts with more primary care physicians, or that is, their enrollees see more primary care physicians who are safety net providers than ours do. I would note, however, that FQHCs are paid on a basis that protects them from differences in what they need to get and what they're paid by managed care plans. However, I would also note that HealthNet is more likely to send its enrollees to DISH hospitals than is LA Care. So I would stand up and say to you that we also care about what happens to the safety net, because if they disappear, the problems we have in this state in providing coverage for poor people are exacerbated. And therefore, we commend to you the idea that having rates based on risk is good public policy. If LA Care's enrollees are sicker than ours, they should be paid more because their expenses are going to be higher, everything else being equal. If their enrollees are healthier than ours, then we should be paid more. And we think the process the department has commenced, while it is not perfect and is difficult, is a better way for the state to move forward than paying someone a lot more money because they spent a lot more money without being able to show that you have high-quality results as a consequence.
Thank you, sir. This is why we have a legislative analyst's office who's going to bring some clarity to the situation for us. So we will, upon Senator Alquist's return, move forward with the adoption of the placeholder language to continue the gross premium tax, but the motion will also suggest that we will keep open the issue of the rates with the receipt of the May revision. Do we have additional public comment?
I would just like to make one that my name is Elizabeth Darrow. I'm the CEO of Santa Clara Family Health Plan, and we are very closely aligned with our public hospital and these rates will prove devastating to our county hospital and our ability to continue to serve in the role that we were meant to as a local initiative.
Thank you for that comment.
And I just need to note one more thing on this, is that this is not all this. There are cases, and you'll see in the data, where certain counties where the LI actually is getting a higher rate than the commercial plan because of the risk-adjusted score. It works both ways.
Thank you, Mr. Douglas.
Mr. Chairman, Leslie Cummings with the Managers Medical Insurance Board. I just wanted to stand up, not related to the details of the rate methodology, but to express our appreciation to the plans and to the Department of Healthcare Services who have, and to the policymakers who created that option for us. We're still so very grateful and very thankful to the Department of Healthcare Services for their work and to the plans for making it happen.
Thank you, Ms. Cummings. Any other public comment? So again, we'll wait Senator Alquist's return to conclude item 7. Item 8 is newly qualified legal immigrant adults, page 27.
Hello, Mr. Chair and committee members. My name is Renee Malo, and I'm with the California Department of Healthcare Services, and I'm here to present on the next couple of items. In terms of the proposal for non-qualified, for newly qualified legal immigrants, the proposal on the table is to eliminate the full scope benefit services for this population, and then to contain and to keep in place the non-emergency services that we're able to cover for them, and to pull down federal funds for this population. Since 1996, with this population, we have not been able to pull down federal funds in terms of covering their full scope Medi-Cal services, and those services are provided at a state cost. And so this is a proposal that's on the table because of the fiscal crisis that we're currently in the Medi-Cal program.
Okay, I know you're struggling with the situation provided by the federal government, but it just seems a little bit crazy to me that they would not cover preventive care and only cover emergency, which means I would imagine everything becomes an emergency, and then they end up covering it, but at a much higher cost.
That is correct. They would cover it at a much higher cost, but because of their documentation status and changes that were made in federal law, federal funds were no longer available in terms of covering full scope services for this population. And the other thing I wanted to comment on is in terms of looking at this particular proposal, and as it relates to health care reform, it would not be a violation of the MOE requirements.
It would not?
It would not be, because the benefits today that we're providing that are full scope benefits, they're provided on a state-only basis. It's only the services that are emergency related or that we cover under for long-term care services and emergency related services and pregnancy related services that we're able to pull down federal funds for this population.
And what about regarding the ARA funds and maintenance of effort?
We can pull them down on those services that we just pull down for their federal funds. So again, it would only be for their emergency-only services that we can pull down with the ARA funding.
And relative to cost shifting to local government?
So it wouldn't necessarily violate the cost shifting because, again, there's no federal funds that are associated with the cost shifts that are going to the counties.
I think this, in terms of this proposal, reducing the benefits would lead to a change, would cause, whether it's the legal immigrants, newly qualified legal immigrants or permanently residing under color law, they will have to look to other places for receiving preventive health care services. So it would either be cost shifts to the counties, to community clinics, or in some cases it's potential that the individuals will go without care.
But again, no threat to either ARA
No.
or to the federal reform?
No.
Okay.
Yeah.
Public comment?
Good Good afternoon, Mr. Chair and members. Vanessa Kahina with the California Immigrant Policy Center. I'm going to keep my comments brief. We actually have some very good substantive commentary from some of our partners today, but we're here in opposition to these proposed cuts to the newly qualified immigrants and to the PRU-call immigrants. We do believe that there would be significant cost shifts to counties, to federally qualified health centers, community clinics, and not to mention the human cost of what happens when these very preventive services that they need become emergencies down the road. So with that, we thank you very much and hope that we'll get this out. Thank you.
So just so for some time efficiency, feel free to make your comments relative to the qualified legal immigrant adults as well as for the PRU-call.
Hi, I'm Tanya.
I want to make sure your red buttons is pushed. Thank you.
Thank you. Good afternoon. I'm Tanya Broder from the National Immigration Law Center, here to strongly oppose the cuts to Medi-Cal for low-income immigrant seniors, people with disabilities, and parents, all of whom are lawfully residing in the United States, most of whom have lawful permanent residence, many of whom are survivors of domestic violence or of other serious crimes who are cooperating with the law enforcement to prosecute their abusers, or who have been brought into the United States for humanitarian reasons and are all here with permission from the Department of Homeland Security to live, work, and remain in the United States. Forcing us, and we appreciate the committee's analysis, forcing them to wait 5 or years or longer in order to get care is bad health care policy. It prevents people from getting treatment early for diseases such as asthma or diabetes, forcing them into the emergency rooms where they would have to be paid for. And for some people, this group is a very small portion of the Medi-Cal caseload. It's much less than 1% of the Medi-Cal caseload, but for the individuals who are affected, this can mean life or death. People who need care early for treatment of cancer and other diseases, or who need medicine for agonizing pain, really could face death if they're not treated, or terrible pain. These are all immigrants who work, pay taxes to support the very programs from which they'd be excluded under this proposal. We urge you to maintain this critical program consistent with longstanding policy in California.
Thank you, Ms. Broder.
Mm-hmm.
Hi, my name is Robin Schultz, and I'm a community organizer with the Korean Resource Center in Los Angeles. And I'm here to share my concerns about the governor's proposal. The Korean Resource Center empowers low-income Korean American immigrants through social services, education, advocacy, and grassroots organizing. Throughout the year, we serve over 8,000 community members in Los Angeles area. On a daily basis, we assist our community members with public benefit programs, including Medi-Cal. This program is critical in helping our recently arrived immigrants for the health care they need immediately, including preventative care. The governor's proposal to deny Medi-Cal for thousands of lawfully residing, tax-paying immigrants would not only be unjust and discriminatory, but also be detrimental to our community's health. As we talk today about programs and policy, I'm here also to remind you about the people. And so I am here representing 1,525 of our community members who have all signed a letter here asking both you and Governor Schwarzenegger to protect this program because, again, we are some of the most vulnerable community members here. So, again, this is about making sure that quality, affordable health care is available to all families and workers. Thank you, and if I could ask the surgeon to provide these to you, that would be great.
Thank you, Ms. Schultz. We'll take care of that. Next speaker.
Good afternoon. My name is Hala Masri. I'm with the Asian Pacific American Legal Center of Southern California, who also opposes the governor's proposal to exclude lawful immigrants from Medi-Cal. One of our partner agencies, the Filipino American Service Group, recently shared with me the case of a client who's an immigrant, a Medi-Cal participant, and a senior. He's forced to scrimp on food and clothing and vision and dental care in order to pay for his medications. And as he stated, I believe that we should at least be allowed a life of dignity. As it now stands, the budget cuts have made that close to impossible. California has long led the nation in advancing access to health care for lawful immigrants, not only to ensure fairness, but also to decrease medical costs. And denying comprehensive health care to Californians will force many to delay seeking treatment. This will threaten their livelihood and only result in costly visits to the emergency room. So for these reasons, the Asian Pacific American Legal Center opposes the governor's proposal. And I'd also like to leave you with a storybook that the Asian and Pacific Islander Community compiled of Southern California. And it really chronicles the experiences of Asian Americans and Pacific Islanders fighting to survive this budget crisis. Thank you.
Thank you, Ms. Masri.
Hi, my name is Carrie Sanders. I'm with the California Pan-Ethnic Health Network, representing the Having Our Say Coalition, which is a statewide coalition of over 50 organizations that works to ensure that health policy addresses the needs of communities of color in California. And you heard from several of our coalition members. We're just here to also oppose the governor's proposal to eliminate full-scope Medi-Cal for PRU-Call and newly qualified immigrants. This is one proposal in a series of proposals to eliminate critical health coverage for millions of Californians. And it will disproportionately impact communities of color who comprise 73% of the uninsured in our state. So, we find this really an interesting time for the governor to be talking about doing this when, we're looking at such a huge expansion at the national level, and we're disappointed that this is the direction that, we're going. We urge you to oppose this proposal. Thanks.
Thank you.
Elizabeth Landsberg with Western Center on Law and Poverty. I would concur with all of my colleagues' statements. We strongly oppose this proposal. This legislature has stood up time and again to protect these services, and we hope you will continue to do so. Thank you.
Thank you, Ms. Lansbury.
Jolena Vorse with the Urban Counties Caucus also opposed to both of these cuts. So we do believe it's a cost shift to counties and would burden an already overburdened system the county safety net provides. Thank you.
Thank you.
Good morning, or good afternoon. Tahira Bazil with the California Primary Care Association, representing over 800 community clinics and health centers. We agree with the statements that were made today, and we oppose the cut to exclude legal immigrants from Medi-Cal services. These individuals will not seek the necessary preventative care that they could be seeking in a community clinic, and will instead quite often go to emergency rooms where the cost will shift. Those that do seek care at community clinics will add to the roles of the uncompensated care that we are experiencing, making it increasingly difficult for us to keep our doors open and serve our communities. So we ask that you oppose this cut. Thank you.
Ms. Bazil. No other public comment? Both items 8 and 9 being the PRU-Call population, we're going to keep this open until the May revision. Moving on to item number 10 is your proposal to implement mid-year status reporting, and that's on page 29.
Yes, and this proposal was looking at the implementation of mid-year status reporting and the reduction of continuous eligibility for children to the extent that at the beginning of January 2011, with the exception of if ARA is extended, then we would look for a later implementation date to the extent that we did not violate ARA provisions, because this would have resulted in a change in eligibility methodologies, which would violate the maintenance of effort for eligibility under ARA.
So I have to challenge you on that. So you're stating that the rollback would not occur if the extension of ARA does happen?
It would be delayed until such time that ARA was lifted. And again, earlier in earlier testimony, part of our proposal was also contingent upon seeking some federal flexibilities and relief.
But aren't you scoring both the extension of the ARA and the savings of it not happening?
That's what we're hoping for, yes.
Because, as Ms. Mullis said, we in the January budget, we're also proposing that there would be flexibilities to the maintenance of effort requirement, meaning we would receive the ARA funding, but they would also allow states to reduce eligibility.
This is your supposition.
That's our proposal, and now we have health care reform that also overlays that, which has a different maintenance of effort that says all Medicaid funding is contingent on keeping your eligibility, your standards, your procedures, your methodologies in place.
It would appear that you want to have it both ways. I don't know that you're going to be able to do that. And then you have anything to say about the ramifications of the proposal?
Well, again, what would happen with this proposal is that to the extent it were implemented, then there would be a reduction in individuals that would be covered under the program to the extent that they did not follow through with the mid-year status reporting requirements. And so we have estimated that there would be approximately 471,000 individuals that would no longer qualify.
Individuals or children?
Children. I'm sorry, children that would not qualify for the program, to the extent that the mid-year status reporting was not completed.
Right.
And then the individuals, their eligibility would run for 6-month increments.
And again, I want to thank Senator Alquist for her leadership and efforts in trying to restore the annual reporting, and I'll pass it on to her when she returns. But again, the ramifications. Children no longer having health care provided to them.
To the extent that they did not follow through, they would not.
But that's,
unless they,
there's no savings for you if we don't have fewer children getting covered.
Correct.
If they're going to drop off as a result of the 6-month requirement.
There would be some savings, yes.
Yeah.
We have estimated there would be some savings.
I just, again, want to point out that there's cause and effect. And when children don't get their health care needs provided, they're going to miss school and fall behind in their studies. And if they do, they're more likely to fail. And this is really very much about our achievement gap. We're not getting kids to school prepared to succeed. And we know that certain populations that have been impacted by the achievement gap are the same communities that are lacking health care provision. So when kids are failing, they're more likely to drop out. And if a child drops out before completing high school, he or she has a 7 times greater likelihood of finding his or her way into the criminal justice system. And you can document this. This is not conjecture. So when we make these proposals, I want to have a full discussion about this. This is not happening in a vacuum.
Understood.
Public comment.
Thank you, Mr. Chair and members. Kathy Sunderling McDonald with the County Welfare Directors Association. We're in support of the staff recommendation here. Maintenance of effort requirements aside, this is not good policy, and it's something that we've long sort of advocated for the longest possible period of eligibility for children. Research indicates that children who lose coverage due to paperwork requirements really do remain eligible for the most part, and our review of data on adults who lose coverage because they fail to turn in their semi-annual reports finds that the vast majority of them come back to the program because they really were eligible within just a couple of months. And so we think that you would see an increase in churning if this were ever to go into effect, this mid-year status report for the children.
Sounds like a lot of waste.
Yeah, I mean, we already don't have enough money to get everything done in a day from an eligibility operations perspective. The governor vetoed $160 million from the program. We haven't received a cost of doing business increase in 2 years now. It's proposed again. So we're just trying to keep our heads above water with increased demand and making sure that we do follow through with everything that's federally required for this program, and that folks who are eligible are on, folks who are ineligible are not on. This is really just a paperwork requirement. It doesn't really have anything to do with are they eligible or not. And so knowing that when children lose coverage, they cost more when they come back after a gap in coverage, it just seems to be really good policy, and it will cost the state less in the long run if we just eliminate this from the books, don't implement it, and move forward with the current continuous eligibility.
Thank you.
Thanks.
Thank you, Senator Carolyn Jenna with the California Medical Association. Just wanted to voice the physician community's opposition to semi-annual reporting. We were official supporters of Senator Alquist's special session bill last year to ensure that California was eligible for the ARA, and also for her bill this year to ensure that the state will also be eligible for the 6-month extension should it happen. We've had multiple delegations go to Washington to advocate for that extension, and it's currently in the jobs bill right now, and so we're hoping that that will go through, and don't believe that this process will save the state any money and will in fact result in children losing their coverage. Thank you.
Thank you, Ms. Genoa.
Good afternoon, Senator, staff. Crystal Moreno-Lee on behalf of Children Now and the 100% campaign. Also here to echo the comments of my colleagues and to urge you to reject this proposal to implement mid-year status reporting for children in Medi-Cal. You said it yourself, 471,000 children would be put at risk. That's just unacceptable. At a time when California needs to be protecting our children, we're taking steps away or we're proposing to do so. I'd also like to further encourage the state and you, Senator, to continue to champion children's health care and really encourage folks to interpret the provisions under the MOE so that we do not jeopardize billions of dollars in federal funding, and neither should we be jeopardizing the health of our children. Thank you.
Thank you.
Elizabeth Landsberg with Western Center, also opposing mid-year status reports for children. Appreciate Senator Alquist and others' work on this issue. We think the MOE is quite clear on this. It says, we can't change eligibility standards, methodologies, and procedures, so I don't understand why it's not clearly prohibited, and hope we can resolve this issue. Thank you very much.
Thank you, Ms. Landsberg, and I'm glad Senator Alquist is back because we've been praising you continuously in your absence, thanking you for...
I'll leave again.
restoring the annual reporting for children. And I just want to point out that the issue of making sure all of our children are covered and with access to health care is a particular issue for both Senator Alquist and for me because it was the Santa Clara County, the first in the nation to provide universal health care for children under 18. And I'm proud that when I was on the County Board of Supervisors, San Francisco was able to follow. We don't like to follow very often, but it happens sometimes. Santa Clara's lead, and we became the second county in the country to do just that. So without objection, I can't imagine there would be from Senator Alquist, that we are going to reject the governor's proposal and then also adopt trailer bill language to continue the annual eligibility.
Thank you.
And then just to conclude our work on item number 7, Senator Alquist, the motion was to adopt the placeholder language to continue the gross premium tax, but at the same time keeping open the issue of the rates. We're also going to get a little assistance from the Legislative Analyst's Office so we can get greater clarity on the rate structure. So then that takes us to item 11 with proposed changes to special needs trust recovery. Welcome back, Ms. Baird.
Thank you. Thank you, Mr. Chair. Vanessa Baird, Department of Health Care Services. A few minutes ago, Mr. Douglas said he's not an actuary, and as I present this proposal, I want to clarify that I'm not an attorney. It can be quite complicated. Our proposal is attempting to untangle our recovery processes of special needs trust from estate recoveries. We believe that this tangling is causing us to lose $3.5 million total funds in recovery for the current year, and we believe that that number will escalate. Basically, our current law allows the courts to establish a special needs trust for an individual who may have received funds as a result of a personal injury, settlement, judgment, or award. These amounts can be quite significant. The trust assets are to be used only to meet the special needs of that person that cannot be met by programs such as Medi-Cal. Federal law considers that this trust is an asset resource for Medi-Cal eligibility, but it does allow an exemption that says that a disabled person under 65 can still remain eligible for Medi-Cal, but upon the person's death, the state will recover from the special needs trust up to the amount that it has paid on behalf of the medical care for that individual. There's a completely separate process for regular estate recovery. And under estate recovery, there are certain exemptions, such as we can defer the recovery if there's a surviving spouse, or we can exempt altogether if there are minor children, disabled children of any age. There was a lawsuit in 2004, Arnold v. Shuri, where a disabled child was able to successfully argue that the special needs trust should have been part of the estate, and therefore, because it was a disabled daughter, the estate would be exempt from recovery. As a result of that, attorneys representing their clients have done a good job of using that case against us, and we are losing recoveries. We believe that the reason for this problem is that our state law doesn't currently conform with federal law. Our law passed early in 1993, and then the federal law
passed later on that year in 1993. So we're attempting to modify current state law to make them conform, make sure that the special needs trust continues to be treated as a special needs trust, not brought into the estate recovery process, so that we can appropriately recover.
Good job. I think you've explained it well. I appreciate your recognizing that you're not an attorney, nor am I, though I play one as a member of the Judiciary Committee, which is where I think this significant policy change should be heard. So, public comment?
Thank you, Mr. Chair. I'm Prescott Cole, staff attorney with CANNER, California Advocates for Nursing Home Reform, and we do agree with the staff recommendation to move this into policy. Special needs trusts are set up, but not only with monies that come in from special events like accidents, or special windfalls. Some of them are funded. Families move some of their money with the idea that an individual who's on Medi-Cal, a certain amount of money will be available to supply things that Medi-Cal will not supply. Now, this has been the policy of the state for years and years and years. And when we have these people on Medi-Cal, some of them are profoundly disabled individuals. And we're talking about the estate of this profoundly individual being able to go to somebody if they have a child that is blind, disabled, or a minor child. That's currently the policy. Now, with the sweeping idea of taking this into the budget and wiping this all out, moving back a little bit, some of these people, had they known that this would have been a possibility, they wouldn't have moved their money into the estate. Because currently, if you have this windfall coming to you, you would accept the windfall of this money coming to you, and you would simply give it away in the month received. You would be ineligible for the Medi-Cal benefits for simply 1 month, and that money would have been moved off. These people made a decision to do that. Now, this has to be a policy to decide whether we want to make sure that people who have children who are blind, disabled, or minor shall be denied the fruits of these people's estate. And we think that is bad just as policy. We'll fight in the policy committee, but we certainly don't think that it should be swept aside. So we'd urge the chair and we'd urge the committee to accept the recommendation of the staff. Thank you.
Thank you, Mr. Cole. Any other public comment? Ms. Barrett, any other comments?
I would just point out one thing, that in the document, when the trust is created and Medi-Cal gets those documents, there are specific provisions that say that the state shall recover. So it is known, and it's stated right up front, that the person will be able to maintain their eligibility, but that the state can recover against the special needs trust upon their death.
Very good. LAO, any comments on this? Dazzled? The motion of the committee is going to be to reject this as a non-budget issue. Without objection, that's our action. Thank you, Department of Health Care Services. Appreciate all your help, Mr. Douglas and Ms. Baird. So we have just 2 items left. Managed Risk Medical Insurance Board. Mr. Mibb, please join us. Welcome back, Ms. Cummings. Thank you for your patience today as we bring this meeting home. So, proposed changes to special needs. We are looking at the governor's proposal to reduce eligibility in the Healthy Families Program, 250 to 200%.
Yes, Mr. Chairman. As part of the governor's budget proposal, which was constructed in the context of the state's incredibly challenging fiscal situation, the governor proposed reducing eligibility for the Healthy Families Program down to 200%. As your committee consultant has pointed out in her analysis, that would have had the effect, had the proposal been adopted in the time frame requested by the governor, of disenrolling about 200,000 children on May 1st and of not enrolling about that number in the budget year. As your committee consultant also points out, federal health care reform does include a provision that establishes an MOE requirement. We are much less experienced in these things than our sister agency, the Department of Health Care Services, and have just begun our analysis of what that means exactly. It does appear to call into question this proposal, but that's something that we are going to be in conversation with our lawyers and the administration about.
Very good. Sure. Senator Ahlquist.
You mentioned that the other department has had more experience in this kind of issue. And my question to you is a process one, and that is, how do you all share information and support each other department-wise when perhaps one department has a little more expertise in a particular area than another?
We unabashedly ask for help, and we have found that the Department of Health Care Services, which does have an incredible amount of experience in federally run programs, has been very gracious with us with their time and thinking.
That's great, and you asked for help early on in the process before too much time has gone by.
Well, this bill was just enacted, and so it's still pretty early in the process for us, and our lawyers are just sitting there reading it. But yes, we will be talking to our colleagues at the Department of Health Care Services. Yes.
Thank you very much.
Yeah.
So before we go to public comment, I just want to make note of the significant impacts made to our Healthy Families program in just recent years. The provider rates having been reduced by 5%, premiums impacting families, limited dental services, co-payments for certain services. It's been not insignificant, and so I don't know that there's any wisdom in further challenging the program. We'll ask public comment to step forward.
Good afternoon. Michelle Wood with Community Health Councils and the Covering Kids and Families Project. Speaking in opposition of this proposal. As a result of passage and adoption of national health care reform and signage by President Obama on Tuesday, it is our understanding that states will be required to maintain CHIP and Medicaid eligibility for children until 2019, as referenced throughout this committee. We recommend that the state reject the budget proposal as it violates the maintenance of effort clause. And this is similar language that was in our legislation, as you all recall. And we strongly urge you to reject this proposal. This proposal obviously will force families to make costly emergency room visits, or delay care for their children and those with chronic illnesses. And I want to leave you with a story I actually received from a family in San Francisco. Stories like David, 11-year-old boy from San Francisco, is why we can't cut Healthy Families. Healthy Families allows David to keep regular appointments for his checkups. At one point, David was being treated by specialists at UCSF regarding a swollen lump growing on his leg. Because of public health coverage, he was able to get an MRI and consultations with physicians and the necessary treatments. No surgery was performed. The lump is still there, not shrinking or growing, and the doctor advised to wait and see how it goes within the next 3 or 4 years, since it won't affect David's daily life. David is healthy and active. His family has peace of mind that he's covered under Healthy Families and can continue to monitor and attend to regular checkups and follow-ups. This story was collected from one of our coalition partners in San Francisco, and I want to thank them. And they've asked me to share how critical it is that this program continues and to keep kids healthy. Thank you, and we ask you once again to reject this proposal.
Thank you.
Crystal Moreno-Lee again with Children Now and the 100% campaign. Also here to echo the comments of my colleagues and to urge you to reject this proposal to roll back eligibility in the program. We do know that it would be a violation of the MOE, but again, I would caution us against interpreting the MOE too narrowly and risk billions of dollars that are on the table. California is not in position to give up any dollars at this point, especially when we're talking about cutting children's health programs. I would further argue that the Healthy Families Program isn't just a program, it's a principle. In this state, and I think in families across the nation, health care for children should be a top priority. I just want to urge you to continue your championship of children, to work as you did last year to keep healthy families whole, including eligibility levels and benefits. Thank you very much.
Thank you. You also should thank First Five for their assistance in that.
Absolutely.
Yes.
As well as the plans.
Yes.
Good afternoon again. Tahira Brazil with the California Primary Care Association, representing community clinics and health centers. I echo again the comments of my colleagues today. The eligibility rollback will provide access barriers to these children, and it will also, as we stated before, force these kids to go to an already overburdened safety net system, of which clinics are a significant component, and will add to their uncompensated care, or making it difficult, for clinics to remain open and seeing these vital children that they should be. So we ask you to reject the proposal.
Thank you, Ms. Bazil.
Thank you, Senator. Members of the committee. Carolyn Jenna with the California Medical Association wanted to voice California physicians' opposition to the proposal to roll back the eligibility in healthy families. We were, of course, very relieved to see the MOE requirements in health reform, but remain concerned about some of the other proposals for supposed cost containment in healthy families, including premiums and the like, that could also serve as barriers to access to these needy children. Thank you.
Thank you, Ms. Genoa.
Hello, my name is Vilma Champion, and I'm representing a Safety Net FQHC clinic, Northeast Valley Health Corporation in LA County. And we have 95% of our pediatric patients that are on either Medi-Cal or Healthy Families. So therefore, we oppose cuts to these programs. As we know, these programs increase access to care for the community we serve. We're actually also opposing the vision elimination under Healthy Families, and I'd like to share a family story quickly with you. And this is a 17-year-old boy who actually, the family was impacted because they were on the wait list. So they waited 2 months to get coverage under Healthy Families, and he was experiencing vision problems, of course, which impacted him in school as well. So the good news is that he was able to get enrolled into Healthy Families and is now able to seek vision care and has glasses, the needed glasses that he has. We also like to share our concern about the premium increases. As we know, there's been already increases in the past, and we know that we're going to probably have about, we're estimating, our organization is estimating about 20% of our Healthy Family membership will fall off of coverage because of this additional increase in premium. So we're really concerned about this.
Thank you.
Mr. Chair and members, Sharita Lane with the California Children's Hospital Association, and like those before me, we are also opposed to this proposal. I do want to mention one small group that is included, and that are children who are eligible and enrolled in the Healthy Families Program are deemed financially eligible for the California Children's Services Program. These children have serious illnesses such as cancer, cystic fibrosis, et cetera. So those children falling off the health care coverage rolls would be absolutely horrible. Thank you.
Thank you, Ms. Lane.
Mr. Chairman, if I could just add one thing. Accompanying the MOE requirement in federal reform, there was not additional dollars provided to states to pay for these programs until the year, I believe, October 2014 or 2013. So that will be a happy day when it comes, because it's going to be an increase in federal financial participation of 22%, taking us from 65 to 88 or whatever. But this obligation of however we decide it, whatever we decide it means as we spend time analyzing it, did not come with additional funds for the program.
So noted, but again, I think the policy issue and concern as addressed by our representatives in Washington, D.C. was children matter and their health is important, and it only gets more costly if we ignore their health. I think that's probably what the decision made in Washington was. I wouldn't argue it. And we'll look forward to that date in 2014. So again, without objection from the committee, I'm going to make the motion that we reject the governor's proposal to reduce eligibility for healthy families and also to reject his trigger, which would eliminate the program altogether. Our last item of the day, to be found on page 35, is the proposal to eliminate vision benefit and increase premiums paid by families. Ms. Cummings?
Yes, Mr. Chairman. As your analysis points out, as part of our efforts to sustain the Healthy Families program, we have asked more of the families that have participated in the program in terms of cost sharing, and have increased the premiums, as you see laid out on page 35 of your analysis. The governor's budget for the next year proposes another increase for families with incomes above 150%. You'll note that there has not been and is not proposed an increase for families with incomes below 150%. And also the elimination of the vision benefit, which is an optional benefit under CHIP law. Dental used to be an optional benefit. It's one that we have always provided, but it is now a required benefit. So it is the last remaining optional benefit. And that is the governor's proposal.
Can you talk to us a little bit about CMS's concerns with regard to cost sharing imposed on families?
Yes. The rules for cost sharing in CHIPRA basically reference the rules for cost sharing in Medicaid, and it places a limit of 5% on family out-of-pocket costs that include co-payments as well as premiums. So we always have to be very careful when we are talking about changes in cost sharing, which we did provide for in this last year, as well as any premium increases, to make sure that we stay away from that 5% level that the federal government has established. And one of the reasons that it's important to us to do so is if we get very close to that level, we are concerned that CMS will require us to begin a data reporting process on these things, which we are concerned that our plans wouldn't be able to do. Present reliance is on subscribers to keep track of their out-of-pocket costs and come and tell us when they've reached a certain level. So that is why it's important to the program to remain distant from the line where CMS would cast its eye upon us.
Very good. Please step forward for public comment.
Crystal Moreno-Lee on behalf of Children Now and the 100% campaign, again in front of you to urge you to reject these proposed cuts to children's programs, which basically a premium increase virtually is. What we know is that any increase to premiums is potentially a barrier to care, and not just care, but a barrier to having the coverage that then facilitates the care that children need. What we just recently learned from UCLA, not just last week, is that we're now at the 1.5 million uninsured children mark. That's up 37% over the course of 2 years in terms of uninsured children in the state, nearly 40%. Like I said earlier, we're taking steps backwards, and our children right now need us to take steps to propel them forward. We would also urge you to reject the proposal to eliminate vision in the program. You spoke of the achievement gap earlier. How can our children succeed if they can't see? They can't see, they can't read, they can't read, they can't succeed in school. So again, I urge you to do what you must to protect our children. Thank you.
Thank you.
Michelle Wood with Community Health Councils, representing the California Covering Kids and Families statewide coalition, speaking in opposition of both proposals. On the premium increase, this would be, I believe, our third premium increase for this category. And if you look at the percentage increase from before February 1st, 2009 to this proposal, this would be a 233% increase since before the February 1st, 2009 premium. We obviously have major concerns around this proposal, as the literature shows us that this would place a financial financial burden on families. And according to the American Public Health Association, a $10 increase in monthly premiums would induce 10% of children to disenroll, resulting in a 6% increase in public health expenditures. And then the elimination of vision, of course, a devastating cut to our children in the Healthy Families Program. Impaired vision affects an estimated 25% of children in kindergarten through 6th grade, and children who lack vision coverage are 3 times more likely than insured children to go without eyeglasses when needed. Obviously, early diagnosis is critical, and we look forward to working with the state to make sure that we keep this program whole as we move forward and prepare our state for national health care reform.
Thank you.
Good afternoon. Tahira Brazil with the California Primary Care Association. Again, we echo the comments of our colleagues. As mentioned, the numbers of uninsured children are rapidly increasing, and this comes at a time where community clinics are seeing significant numbers of uninsured in their clinics. We ask that you reject this proposal in light of health care reform that seeks to protect children's health care services. Thank you.
Thank you.
Mr. Chairman and members, John Valencia representing VSP Vision Plan. We cover 700,000 of the 900,000 kids in the program, and consistent with our not-for-profit status, we do so at roughly in excess of $1 million a year loss. We're endeavoring to work with Mr. Mibb to structure a benefit redesign to try and bring the costs down even further. We do oppose the outright elimination of the benefit, of course. We'd like the opportunity to continue working with them. One example that we surfaced in the Assembly Committee would be to consolidate the materials and basically the frames and lens cost into a consolidated cost, provide discounts to the purchasers, really just to try and figure out a way to keep the benefit available while driving its costs down even further. But in the meantime, we ask that you reject the outright elimination of the benefit and give us an opportunity to work with Mr. Mibb, see if we can't come up with an alternative.
Thank you, Mr. Valencia.
Mr. Chair, members, Carolyn Gino with the California Medical Association just wanted to voice opposition to both of these proposals and the barriers to access they would pose to these kids. Thank you.
Thank you, Ms. Genoa. Yes.
Mr. Chair, Bruce Lee with Finance. Just to quickly flesh out the matter in context of other states, in 2009, 14 other states did increase their premiums for children at 200% FPL, including Arizona and New York. Arizona actually doubled their premium from $17.50 to $35. The highest states at 200% FPL would include Arizona at $35, Rhode Island at $30, Minnesota at $28. Just to flesh it out, finally, there are discounts available for the Healthy Families Program and their premiums. The Community Provider Plan provides a $3 discount, and if you're using advance payments, a 25% discount, which would bring the net premium down to around $20 per child. And while other states, generally speaking, do cover eyeglasses, at least 2 states, Utah and Nevada, do not, and perhaps others. Thank you.
Thank you. And not to go unnoticed, if you're going to give a full report, that monthly premiums paid by families for their children's enrollment were increased in 2005 here in California and then twice in 2009. So I think we're keeping up with the other states, if that was your point. Senator Cox.
Mr. Chairman, I apologize about having to leave, and I appreciate the fact that I'm only a visitor on this budget committee today.
And a welcome visitor.
I do, in fact, want to say to you, it is not reasonable to believe that premiums cannot be increased. And I appreciate the fact that there was an increase in 2009, and I think you will recall that I worked very hard to be certain that we, in fact, had healthy families with respect to the coverage. But it's not reasonable to believe that premiums are not going to go up, and you just have, I believe you have to recognize that, and unfortunately, to the extent that you don't make some sort of increase on an annual basis, it will just create a bigger problem next year and the year after next. And so I would encourage you not to reject this program just out of hand, but to try to figure out what a perhaps more reasonable rate would be for this year, recognizing that whatever you don't do this year, you're going to have to double next year, and ultimately you get into a situation where you do in fact have people who cannot afford to take care of the coverage. So,
Senator Alquist.
Thank you. Just some broad comments across some of the different topics today. the budget situation is just so tough, and now we also will be having certain mandates from the federal government that will affect what we can or cannot cut, which means we will have less flexibility. And the 2 points I would like to make would be, number one, that we really look at issues that are a matter of life and death, where we must have certain services. Then the other thing I think we should look at is to see that we don't want to make one cut in one area of general fund, when in doing that, what it really does is shift the cost exponentially and quadruples the cost 2 years down the line in another area. So I'm asking for a very thoughtful approach, which I certainly know we will have with Senator Leno and with Pro Tem Steinberg, and we really need for all of us to look at issues that way. Thank you.
Thank you, Senator. And thank you again, Senator Cox, for joining us today. With regard to this last issue and the proposed elimination of vision benefit, I was among those 25% of kindergartners to sixth graders who recognized that I was severely nearsighted by the fourth grade. And I was fortunate enough to be able to get eyeglasses. I couldn't see the blackboard. I didn't know what was happening. But it's more than not being able to see the blackboard. It really would make it that much more difficult for a child to engage in any kind of sports. And as personalities are developing, to not be able to pick up on the nuances of facial expressions and eye contact because it's all just a blur really would have impacted my ability to grow socially as well. So it sounds like a small little elimination, but I think it has profound impact on the development of a child, and how heartbreaking to deny one child over another just because of the cost of the benefit. In any case, I'm going to follow Senator Cox's good advice today, since we don't know exactly what our fiscal situation will be come the month of May. I'm going to end the meeting on an upbeat. We're $2 billion ahead of projected revenues in the first 2 months of this year. So we don't know how much more we may be up. Hopefully it's not going in the other direction in the months of March, April, and May. So without objection from the committee, we'll keep this item open.
And vision?
Yes, both items will be kept open. So thank you for joining us today, and thanks to our public as well. Thank you, LAO. Thank you, Finance. Thank you, committee members. With no other business before the committee, we are adjourned.